Good day, everyone. Good morning here on the East Coast. Good afternoon to our colleagues in Botswana and around the world. I'm Glenn Galton, Director of the Center for Global Health. It's just an extraordinary pleasure to welcome you to the second day of our fantastic celebratory symposia honoring 20 years of collaborative work between Ministry of Health, University of Botswana, and the University of Pennsylvania and Children's Hospital of Philadelphia. We had a fabulous day yesterday with a really inspiring number of stories and talks of individuals impacted by and impacting the great work there in Botswana, many of which extends to other parts, of course, of sub-Saharan Africa. I want to begin today with a little bit of a reminder of something that was said yesterday. So I'm going to share my screen very quickly and just highlight again for everybody some of the key individuals who were involved in starting this relationship. I think sometimes we forget, when we're in the middle of something, but looking back after 20 years, it was an awful lot of work and in some cases, some convenience and serendipity that led to PEN's being in Botswana. Our original founders, I think the first one in Botswana was Steve Gluckman, followed shortly by Harvey Friedman. And it was, of course, Harvey who really launched BUP and formed BUP together with many colleagues shown here on the picture. I said something yesterday about Children's Hospital, and Andrew's picture is up here, Liz and Tonya, and now Miriam Brooks, and many, many others over the years. CHOP is there's no relationship that I know of in academia like the one between PEN and CHOP. We, as faculty, we're one institution, even though corporately, they're actually separate organizations, and it's an amazing, amazing relationship between the two parties. So, we say PEN, but we all really, it should be. I guess it would have been too long of an acronym beyond BUP, but we should have CHOP in that acronym as well, really. And of course, all of our wonderful colleagues at UB and in the ministry, and spearheaded by, in many ways, by Watokwa Doreen, Johanna, Leoto, and so many others, and great faculty at PEN who have remained and continued to be involved. And of course, Andrew and Liz fall into that space. But of course, others like Robert Gross and so many others at PEN. And then there's a list of people, and I think it's maybe 2 or 3 generations of them now that have come through the organization as founding faculty or key individuals. And I've seen many of them listed in the, as participants, and a couple of them have dropped me notes yesterday, and it's great to catch up with people. Some who are still there that we haven't heard from as directly, like Giacomo, but other folks like Matt and Miriam, Chelsea, Joe, Shawa, Nicola, Savara, and on and on and on. So many great people involved that made this relationship such a success, and that continue to contribute, and many of whom remain in Botswana, continue to contribute to your country in so many great ways. So I just want to acknowledge that while the institutions are important, obviously, as in all things, it's really about the people. So thanks to all these great people. I'm going to very quickly run through the agenda, and then we need to get started. So let me also screen share one other item. Where did I do with it? Nope, hang on, I'll figure it out. At some point, slideshow. All right, I'll figure these things out, no worries. Okay. All right, can you see that okay, Corrado?
It's perfect, thank you.
Yeah. Okay, so I want to very quickly run through the agenda, remind everybody the website Symposia, the URL to get to the agenda if you want to see the very detailed agenda. I'm going to click through it pretty quickly here. Following our opening remarks from the ambassador and VC Norris, we're going to have some really inspiring talks about partnership, some events and stories from individuals who have been nurtured through this relationship, just how the relationship has impacted them as individuals and their personal and professional development. And I think it's going to be an inspiring listen at 9:55. Then Corrado and others will talk about, and Miriam will talk about the launching of BUP strategic plan. And then we're going to reflect a little more broadly on the health priorities in Botswana, conclude with our closing remark, and then on as yesterday to the poster session. So we have the poster session. We had a little bit of a blip yesterday leading into the poster session. It's going to be run yesterday as it was, today as it was yesterday. 4 concurrent sessions. They'll repeat in 2 rounds. They'll work more smoothly this time, I promise you. You go to in the chat, there'll be a link. You click on the chat, you get to the poster site, the Zoom site. You click on the list at the bottom there, the little 4 boxes at the bottom. It'll open the breakout rooms. You click on one of the breakout rooms. When you click on the breakout room, I had a problem with this one, being IT challenged at times. And then it will ask you to join. And then when you click join, you have to say yes as well. And then when you do all those things, you'll get into your room. And again, the poster sessions will repeat for 30 minutes, 35 minutes, and then they'll cycle again. So you can either jump between rooms or go to one and then flip and go to another. And I want to apologize again very briefly, because at the end of the second poster session yesterday, the IT systems actually at UB went down, and so our moderators went off. So that kind of was out of everybody's control because the whole IT system went down. So hopefully that won't happen again today. Again, we'll give instructions in the chat room, but I'm sure it'll go more smoothly than it did yesterday. Okay, let me stop share. There we go. All right, so we're going to kick off our session with a welcoming message first from Ambassador Craig Cloud. And we've just been so fortunate, as have all the US institutions in Botswana, to have tremendous support from the US government and the Foreign Service and the State Department. And no exception with Ambassador Craig Cloud. Craig is I shouldn't be quite so familiar. Haven't had a chance to meet him yet since I haven't been to Botswana since the pandemic. Ambassador Cloud is a career member. I am going to see him so this spring. I'll be spending some time with you, Ambassador Cloud. He's a career member of the Senior Foreign Service and has served as an American diplomat since 1992. Most recently, it was posted in Afghanistan. So that I'm sure was a stressful time. Prior to this assignment, he was in New Delhi, India, and prior to that in Eswatini, and that was earlier from 2010 to 2013. And actually, he's been posted in numerous positions throughout Africa, South Africa, South America, Europe, South Asia, 9 embassies in total over his tenure. He possesses a really deep knowledge of the South and Central African issues, having been in the region for many, many years, a tremendous expertise in HIV/AIDS programming and advocacy, which again was a major reason why I know he was selected for this posting. And he follows a long line of ambassadors, Ambassador Nolan, Gavin, Earl Miller in particular, I remember extraordinarily well, who have just done an amazing, amazing job supporting all of the US institutions and supporting the country of Botswana in the US's efforts to help them grow and fight the terrible AIDS epidemic, but also all of the other health imperatives that the country is looking to improve. So I'm going to stop and turn it over to Ambassador Cloud. Ambassador Cloud, welcome. Thank you so much for joining us today.
All right. Well, thank you so much for having me here. It's really exciting. Dumelang Baitu. I can't think of a better way to spend my afternoon. Good afternoon to everybody here in Botswana. Good morning to everybody in the United States. It really is an honor to join you in marking the 20th anniversary of the Botswana-UPenn partnership. Since 2001, this partnership has strengthened the U.S.-Botswana bilateral relationship through the work of the University of Pennsylvania, Botswana's Ministry of Health, and the University of Botswana to build the healthcare and research capacity in Botswana. And I want to thank the Botswana-UPenn partnership team for taking a comprehensive approach to train healthcare workers across Botswana in the treatment of HIV and AIDS. This has included the development of postgraduate training programs in internal medicine, global health experiences for UPenn trainees, and the development of joint research that addresses issues relevant to the health and welfare of Botswana. Botswana UPenn doctors and healthcare practitioners are on the ground here, providing inpatient care at Princess Marina and the Yangabwe hospitals, outpatient care at HIV clinics, and outreach care at surrounding district hospitals and local government clinics. Botswana UPenn physicians and nurses also run a referral clinic for complicated HIV/TB co-infected patients. And this incredible work has touched the lives of so many families in Botswana. And today we're here to honor these healthcare professionals in this incredible partnership. How exciting to be celebrating 2 decades of achievements with the Botswana UPenn partnership. This milestone offers the opportunity for us to reflect on successes, best practices, and lessons learned, and to chart the way forward. In 2004, the Botswana UPenn Partnership Program first received funding from the US government through the President's Emergency Plan for AIDS Relief. Most of you know it as PEPFAR. But this is a program that provides US government funding to nations affected by HIV/AIDS, including Botswana. A combination of PEPFAR funds and research grants supported approximately 60 full-time physicians, nurses, social workers, and auxiliary healthcare personnel working for UPenn in Botswana. There are a number of notable achievements resulting from PEPFAR's involvement in the Botswana UPenn partnership. Health providers have learned how to spot TB in a chest x-ray. Healthcare workers use cell phones as tools to make clinical diagnoses and to obtain health training. And the Botswana UPenn partnership helped create new clinical guidelines for the care of patient care in Botswana. Access to health for all remains a priority for the US mission in Botswana. Promoting university partnerships and academic exchanges that are sustainable approaches to solving global problems is one of our top priorities. And in 2019, the United States Department of State launched the University Partnership Initiative to expand existing links and promote new partnerships at the university level to strengthen Africa's educational institutions as instruments of national development. So fast forwarding to 2021, the University Partnership Initiative has linked 110 African universities in 8 countries with US institutions of higher education, beyond what we already had. The US government is grateful for its ongoing partnerships with US and African universities, and we're constantly seeking ways to strengthen this cross-cutting collaboration to address the real-life issues, including global health. I personally have spent 20 years of my professional life in sub-Saharan Africa, and during that time, I have seen a diagnosis of HIV/AIDS go from being a death sentence to becoming a manageable chronic disease. This miracle has not only been possible because of the educational networks, research, academic and professional skills development, and exchange of ideas. It brought on through partnerships like this, like the one we're celebrating here today. That is the only reason that we have realized this miracle. And I'm really excited to learn more about BUP's important work in Botswana over the past 20 years, but even more excited to see how we can build on this incredible foundation for the next 20 years. Congratulations on the partnership. I'm really excited to be here today. And as we say in Botswana, pula.
Thank you so much. Thank you so much, Ambassador Cloud, for those fabulous words, and very, very well spoken. The commitment of not just the institutions, but the US government to so many places around the world, I think often gets lost in all the other politics that we at times wade through. But there's no better evidence of that than the wonderful relationships and outcomes we've had in Botswana, working with our colleagues there. And I look forward to seeing you this spring. I'll be there for sure, relatively early in 2022. So we're going to move on to our agenda today. I want to remind everybody that we'll be posting throughout the day. It's over on my right side on my screen. In the chat, there's a Zoom link for the meetings, and that will hook you up a little later on to the poster session. So that'll appear throughout the day, and it'll reappear at the end of the session, so you can go to that. Also want to remind everybody that there is a chat room. So as questions come up, please post them there, and the moderators of the sessions will read them as we go along. And that'll be the vehicle to pose questions to our participants and speakers. And lastly, and I forgot to remind yesterday, but everybody behaved themselves quite well. This is a recorded session. So just to remind everybody of that. All right, Watokwa, you ready to go? I'm not going to introduce Watokwa again. We did that yesterday. Everybody knows who you are.
Yes, yes.
Watokwa, of course, the Dean of the Faculty of Medicine, and she'll introduce VC Norris.
Good afternoon, good morning, colleagues. I have the great pleasure to introduce this afternoon Professor David Norris, who is the Vice Chancellor of the University of Botswana. Now, Professor Norris has a PhD in quantitative genetics and animal breeding from Michigan State University in the US. And prior to coming to Botswana, he was the Deputy Vice Chancellor at the Botswana International University of Science and Technology, and was responsible for research and innovation. Professor Norris is an experienced leader, researcher, and teacher. And so we are really excited to hear from him this afternoon. Welcome, Professor David Norris.
Thank you very much, Dean. Really appreciate it. And let me just start by saying good morning to my colleagues in the US, and good afternoon to my colleagues here in Botswana. And let me just start by recognizing the ambassador, Ambassador Cloud. I should indicate to you that I met Ambassador Cloud this morning as he was observing the vaccination process that is going on right now. As you know, the United States of America has been spearheading efforts in assisting us with vaccines. And he was there just to see how the process was unfolding this morning. And I want to take this time to appreciate and thank the ambassador, and also to appreciate the nation of America, United States of America, for being there for us. I have a presentation that I'm going to share with you now as I give my keynote address.
Professor Norris, you are muted.
Yeah, no, I'm still, I'm trying to get the presentation. Thank you, just give me a few minutes. Thank you. Yeah, this is it. Just a few minutes. Thank you. There it is. I can not make it larger. Thank you very much. There it is. I'm going to be speaking to transformational partnerships and sustainability, and I will not confine myself specifically to this partnership. But I'll just say things a bit in general. But before I do that, let me just say that the UPenn-UB partnership is one of those partnerships that I'm really, really proud of. As the Vice Chancellor of the University of Botswana, we are really proud. This is one partnership that has really yielded results that have been very positive outcomes from this partnership. One of them being capacity building for our staff and research that is impactful in society. one of the things that we are doing and saying at the University of Botswana in our transformation journey is that we really want to do research that solves societal challenges. And I want to say this without an ounce of doubt, that the UPenn-UP partnership has just been that. The outcomes have really been great for us, and we all can see the benefits of this partnership. I must indicate that some time back, I think a decade ago or more than a decade ago, the United Nations produced a report, and this report was co-chaired. The panel that developed this report was co-chaired by some prime ministers from Mozambique, Norway, and Pakistan, and then British Chancellor Gordon Brown. And now the report showed one thing, that is the United Nations work on development was described as being fragmented and weak, and that its governance was called or characterized as being inefficient and ineffective. And now, the more than 20 United Nations agencies were active and competing for limited resources without a clear collaborative framework. Now, to show the level of fragmentation, each of these agencies had its own IT system. Now, if you look at the Sustainable Development Goals of the United Nations, the Sustainable Development Goal number 17, SDG 17, is all about partnerships for achieving the set goals. And this is how it reads. It says, strengthening the means of implementation and revitalize the global partnerships for sustainable development. This is one of the key SDGs, which speak to the importance of global partnerships for efficient and effective sustainable development. Target 17.6, which is aligned with this SDG, talks about knowledge sharing and cooperation for access to science, technology, and innovation. Target 17.8 talks about strengthening the science, technology, and innovation capacity for least developed countries. Target 17.16 is about enhancing the global partnership for sustainable development. Target 17.17 talks about encouraging effective partnerships. And I think what the UPenn-UP partnership has been doing is really achieving what the United Nations are promoting. And this is something that we can all be proud of. The reality is this, that traditional linear model of research into practice has some shortcoming. The shortcoming is that there is knowledge production, but we don't have knowledge transfer or knowledge translation. The collaborative and interdisciplinary research approaches that have been found to enhance a fast and more systematic use of knowledge. They enable and enhance both the use of research and increase the amount of research that is relevant to end users. I think that is the greatest interest for me. That is the research that you'll be doing. So what this is saying to us is that research that is not done through partnerships usually do not become relevant to the clients or to the end users who are really in need of such solutions. And importantly, it also says, with these partnerships, they lead to demand-driven research, not researcher-driven. It's demand-driven research that serves the development needs of communities. And for us really in developing countries, this is the most important thing. This all speaks to impact. Now, you will all agree with me that most of the problems that plague our modern societies have a distinctive, complex nature, which is not amenable to the traditional linear way of doing things or silo interventions. The fact is, societal problems are complex. If I may just give examples: traffic congestion, environmental problems like water pollution, urban and rural planning, illicit drug use, homelessness, domestic use, and all these are very complex. And in the area of healthcare, if you think of HIV/AIDS problems, childhood obesity, HIV and AIDS, which I've already mentioned, high blood pressure, cancer, broad community health priorities, mental health, and so forth. All these are complex. Now, what we find, which is a challenge, is that we all want to be solving these problems without collaboratively forming partnerships. And what we find is duplication of efforts, fragmentation of services, competition for limited resources, and most importantly, which sometimes we don't take very seriously, is distrust. And now, related to what I've just said, the types of problems and issues impacting on families and communities we work with are often multifaceted. They can be confusing and hard to define. That is why we call them complex. These problems are therefore problems that are beyond the scope of any single organization to understand and to respond to. There's often issues of disagreement about the cause of the problems and how to address these problems. And of course, the problems can only be addressed, but not completely solved. There's also difficulty to define, these problems are difficult to define because different people will have different opinions about the cause, the nature, and the extent of the problem. It is often the social complexity rather than the technical complexity that makes complex problems hard to address. A few years ago, I got to learn about what you call wicked problems, which essentially are these complex problems. These are problems that are difficult or impossible to solve because of incomplete, contradictory, and changing requirements that are often difficult to recognize. And now, these wicked problems have many interdependent factors, making them seem impossible to solve. Now, these factors, as I've already mentioned, are often incomplete. They constantly change and are often difficult to define. Now, what is being proposed is that because these factors are often incomplete, constantly changing and difficult to define, solving wicked problems requires a deep understanding of the stakeholders involved, and an innovative approach provided by what you call design thinking. Now, we see these complex problems, even in the health sector. Actually, many issues, such as healthcare and education, are just some of the examples of these wicked problems. Let me just share a few characteristics of these complex or wicked problems. And this I'm getting from Stuart from his writings 2014. The solution to the problem depends on how the problem is understood. The problem is not really understood until it has been addressed. The problem cannot be completely solved. And I think, as I say this, we can even recognize some of the problems that we deal with in the health area. Now, people involved can have very different worldviews and have radically different views about the causes of the problem and the best way to respond to this. We may not know beforehand what impact our interventions or the researchers' interventions will have. And every complex problem is essentially unique. The cause and effect is unknown and sometimes even unknowable in codes. And every solution to a complex problem may have unintended consequences. Every complex problem can be considered to be a symptom of another problem. So you can see the complexity of these wicked problems. Now, how should people be responding to these complex problems? And I'm just getting this from the Australian Public Service Commission. They have just said a few ways in which these problems can be addressed. One being that there should be a holistic rather than partial or linear thinking. And there should be innovative. So really when you solve them, you must be innovative and you should be able to be flexible. You should be flexible in your approaches and not rigid to say, I believe this is how I must solve this problem. No, there has to be flexibility. What is critical, which I've also put in bold, is that there should be ability to work across agency boundaries. And this speaks to partnerships. You should be able to effectively engage stakeholders and citizen communities in understanding the problem and identifying possible responses. And of course, a comprehensive focus in our strategy is required. Tolerating uncertainty and accepting the need for long-term focus is another way in which you can address or respond to these complex problems. As I indicated earlier, complex problems are beyond the scope of any individual entity. And therefore, as I've already mentioned, there's a need for a broad stakeholder engagement. And now, Scott says, the key to effective approaches to tackling wicked problems is creating a shared understanding between the stakeholders about the problem and shared commitment for the possible solutions. This does not necessarily mean that there's complete agreement about the nature of the problem, but that the stakeholders understand each other's position well enough to have intelligent dialogue about the different interpretations of the problem and to exercise collective intelligence about how to solve them. Health, colleagues, ladies and gentlemen, is a complex as a concept is complex, and the promotion of health requires consideration of its wider social, economic, cultural, and environmental determinants. Interagency partnerships can provide a holistic approach towards improving health and reducing inequalities. Now, it has been observed, as you may have observed those who are actively participating in this partnership, that partnerships are most successful when there is a clear goal for the partnership and that partners are working towards a shared vision. Sharing the same vision is important, but even more important, I would say, is diversity. The diversity in background and expertise, I believe, contribute to the partnership strength due to what I call complementary knowledge, skills, and experiences. And importantly, there has to be a willingness. This is vital. There has to be a willingness from each other for genuine partnerships to be established. Where one party says, I know better, or I know more, or I'm more experienced, then that's where the problem is. Each partner's experience, no matter whether it's so extensive, whether it's highly recognized, that experience, that skill must be embraced and respected by all. That's critical. That's how you can have genuine partnerships. And the fact of the matter is, given the positive outcomes that have been coming out of this partnership, one could say with confidence that some of the things that I'm mentioning, the willingness to learn from each other, trusting each other, I would say those are the things that are already in place. That is why we are making progress in this partnership. Respect and trust, critical. Involving multiple stakeholders from different backgrounds requires respect. You see, these are some of the soft things, or some of the things that we tend to not take very seriously, where we are more concerned about the skills, the expertise, and so forth. But leaving things that are very difficult but often referred to as soft, when they are not really soft, issues of respect, issues of trust, to ensure that the partnership is sustainable and can achieve systemic transformation. What is critical is transformation, transforming lives, impacting on lives. Now, mutual trust among individual members are key to sustainability and achievement of a common goal. And equally important, as I've said, is the respect for the skills and expertise of partners. You don't say, these ones, they don't have the necessary skills. Even those that are sent out to the field to collect data, just collecting data are very, very important. Now, interactions in these partnerships must also be collegiate in a sense of respect and gratitude for the skills, expertise, and time offered by partners is certainly imperative. The reality is that designing partnership for success is challenging, very challenging. One of the things that I always say when my colleagues there call me to be there to preside over signing of MOUs, MOAs, and so forth, I say, I already have and have found many MOUs stashed in cupboards, gathering dust, and so forth. those agreements never have been implemented. Some of these partnerships that we try to build, they just collapse or die at infancy stage because we don't pay attention to a lot of things that are very, very important for these partnerships to be fruitful. Now, these partnerships can also succumb to collaborative inertia. They experience slow progress, or you can realize little or no tangible outcomes. The UPenn-UB partnership has been there for a while. And the risk for this to succumb into this collaborative inertia is there. And that is why it's very, very important that we look at those things that will always give impetus to more progress. Because if we overlook these things, then we may not move forward with the enthusiasm and the achievements that we're making. Now, some of this slowdown could be due to distrust conflicts, process, and power differences. And it's critically important to identify these factors and intervene to move the partnerships in the right and positive direction. There's this which you may not see, unfortunately. I think I should have just typed everything. I just extracted it from where I got it. But I'll try and just read out what I'm saying. This is just about the partnership life cycle, where you are at the formation stage, where you are exploring each other's needs, looking at what is possible, sharing common cause, and so forth. And the possible actions where you can create opportunities for people to get to know each other, to meet on neutral ground, encourage focus on common vision, and so forth. There's also a stage which could be a frustration stage, where you could be having hidden agendas, individual questioning the purpose of the partnership and reasons for being there, doubting each other, competing for credit and control, and this and that. And also the actions. What should be done when you are in a frustration phase? And there are a number of actions that can be done, including revisiting the common purpose, giving more time, planning quick wins, creating climate for open expression, re-emphasizing the benefits of the partnership. But you could also be having a functional phase, which I believe this partnership has even gone beyond the functional phase, where you feel renewed vision and focus. You've established clear roles and responsibility. You could now even be at the flying phase, where the achievement of the partnership has been made. The partnership priorities are central to partners' activities, where you need to keep working on the communications and anticipating future challenges and so forth. So you have all these phases. So one needs to be determining, where are we, looking at the characteristics of how are we functioning in this partnership. So we should be looking at saying, are we at frustration stage? Are we at functional stage? Are we at flying stage? Are we doing things very well? Or maybe we are now in a downturn. We are failing. There's disengagement, there's loss of commitment, there's recurrent tensions, and so forth. And if you are at that stage, then you must think of revisiting stage one, which is the formation stage, so that you then set priorities, come to understand your common goal or common vision. Now, let me just go back a little bit and just talk about the fact that in Botswana, we've always really believed in choosing the right partners. And long before independence, Botswana was choosing partnerships instead of going alone. Botswana cleverly partnered with some forward-thinking visionaries to petition their case for protector status with the British Crown. Remember, South Africa wanted to incorporate us into South Africa. So we have to seek this protection. So we have to come up with partnerships that can protect us from being amalgamated into South Africa. And now, the other thing is the discovery of natural resources in this country has been managed in the national interest through careful or carefully blended partnerships that provided capital and technologies. The impressive economic growth rate of this country, which was achieved some years ago, was through carefully selected partnerships, giving the nation access to wealth from its mineral resources without the need to turn Botswana into a mining economy, which had brought the resource curse to too many nations in Africa. Now, today, Botswana is again looking outwards to stakeholders who recognize its unique value and who in turn can accompany Botswana through the shifting alignments of the global market. The University of Botswana has played, and I think it's important that I mention this, that the University of Botswana has played a very important and historic role in creating the people who pioneered our new state and our expertise-based system of public management. The university must now rise to the demand for a logical sequel to a rapid and successful initial growth period. And this will consist of acquiring the reliable knowledge that will allow a tapering of public spending in the old mold of resource-based economy and in favor of a blended model of carefully planned public, private, and civic partnerships as are appropriate to a human capital-based economy. As a university, we are acutely aware that a national comprehensive university such as ours is the eye of the needle through which all current knowledge and learning must pass from one generation to another. Whatever we cannot fit through that needle is lost intergenerationally and therefore lost to society and its future. As a university, we are saying we have to pack, repack, balance, and optimize knowledge in the interest of better citizenship and participation in the coming society on which we are already betting our national well-being. Now, our conception of knowledge, skills, professionalism, collective purpose and norms is a permanent cross-section of our knowledge society. Therefore, our diligence, self-criticism, and aptitude for making and keeping partners who are on the same journey as ours is basic, is very basic to Botswana retaining a human capital economy. We have a new strategy at the University of Botswana that requires the university to drive stakeholder value by, among other things, outfacing its expertise and resources to mobilize and catalyze the national knowledge base into the productive resource for growth and for recovery and growth in line with Vision 2036, which is themed prosperity for all. Now, therefore, UB intends to package offerings that are attractive to the most efficient use of public funds and private investments, as well as its reputation as a trusted broker of investable and fundable relationships within SADC and Africa and beyond, as value proposition for making Botswana fundable through third stream income. The new strategy requires that UB enters the national agenda on knowledge economy with a specific offering to convene a coalition that can shape, sustain, and support the growth areas that are more likely to provide rapid diversification of sectors by strongly linking Botswana to global opportunities. And all these can be achieved with the kind of partnerships such as the one that we are here for today. Now, this coalition must be able to implement a projectized process as an economic growth point for Botswana's human capital in the four generic areas most relevant to Botswana's knowledge economy, which are the bioeconomy, which emphasizes health and food sectors, education, which emphasizes distance and adult learning hubs, and tailored certification for knowledge economy competencies, as well as the creative and design disciplines. As I conclude, let me say this, that our relationship with UPenn has been a key proving ground of these collaborative ambitions and repositionings, and we look forward to more years of working hand in hand with UPenn in what we hope we can shape in our own ways into a better new normal. I thank you.
Thank you, Professor Norris. We have been given a couple of minutes more for any questions. So if you have any questions for Professor Norris, there's one. The first question is from Glenn Galton. My question to the VC is, oh, what happened? What happened to the question? Okay, how does how do you envision linking the university, which is the faculty and trainees and academic environment, to the economic development sector in Botswana while preserving academic scholarship? How do you envision linking the university, which is its faculty and trainees and academic environment, to the economic development sector in Botswana while preserving academic scholarship?
Thank you very much. For a public institution like ours, funded by public money, it's fundamentally important that what we do has relevance to society. And in Botswana, as most of you would know, we talk about knowledge economics, which are economies that are really propelled by intellectual capacity. Now, it is natural for us as a university that we should be spearheading government's efforts in transforming the economy into a knowledge economy, because we create the knowledge and we must transfer this knowledge. And therefore, what we do should not be what we do for ourselves, but what we do, are we solving problems that society faces? Are we saying to government, say for instance, after this COVID, the negative impacts of COVID, including the finances that have been hit hard, our economists, for instance, can they go out there and say, how do we revive the economy? We talked about those areas that are very, very important for us as a nation. The health area, food, creative arts, climate change, and so forth. As a university, how do we solve these problems? What is fundamentally important is a balance between knowledge, what you call blue sky research, and impacts. So applied research, basic research, how do you create balance so that you can always make sure that you don't take away that freedom that academic staff usually would say our freedom is being taken out. And then the balance is critical. Thank you very much.
Thank you. There's another question from Professor Kancheda. My question to the VC is, what can organizations do differently to be better partners? Unfortunately, often organizations are incentivized to compete rather than collaborate.
That is very true. For better collaborations, really, I mentioned some of the things where you understand from the onset that you understand what you really want to solve. The vision, common goals. That's fundamentally important. And then, of course, I think one of the things that we also lose out is that usually you would have academic colleagues partnering, but not involving those that you want to help. So, for instance, particularly in the health sector, you are thinking of men and women out there in communities. You are solving their problems. Now, the weakening of the partnership will come when you don't involve those people that you are trying to serve. You're absolutely right. You have the problem that the way we do things sometimes promotes people to compete. But I've been observing that even the funders nowadays, they are saying they want to see when you bring in a proposal for possible funding, they want to see, are you collaborating? Are you working together? Are you pooling your resources? So that's very, very important. The funders now are actually even moving us and compelling us to do things in a collaborative manner where you can effectively use the dwindling financial resources.
Thank you very much, Vice Chancellor Norris. We have another minute if anyone still has a question to ask Professor Norris. Otherwise, I will hand back to Glenn Galton. Thank you, Professor Norris.
Thank you very much.
Thank you, Professor Norris. Thank you, Professor Norris, thank you so much for that wonderful overview of the university and your perspective on where the university is headed and its critical role in the country. I spend a lot of time in various countries around the world, and even here in the United States, there's a lot of talk about knowledge-based economies, but exercising that in a practical way, and the role of universities in creating knowledge economies is critically important in how we train our faculty, train our students, and nurture our faculty in this space is very important. So I'm just, I'm so optimistic about what you've said and where Botswana will be. So thank you for that and for your continued leadership and your wonderful partnership, again, certainly with Penn, but I know with many of the other institutions working in Botswana. We're really all in this together.
Ken, there's one question from Robert. I don't know whether you want to read it or we just.
Where's the question? Oh, you have a question. All right, Robert, go ahead. VC, Norris, are you still there? Is
yes,
Professor Norris?
Yeah,
Robert, I can't see your question. I have a question, but I don't see the question.
Can I read it?
Yeah, if you can see it, sure, go ahead.
Yeah, it says, Dear Professor Norris, Rea leboga for the inspiring talk. Can you answer how you balance the interest of the Botswana stakeholders and the existing trusted partners, where there is some, but not complete overlap between desired proposals by the Botswana and the skills and interests of the foreign partners?
Thank you very much. What you are saying really goes back to those the model that I spoke about a little earlier. Just from the formation phase is very, very important what you want to achieve. And the realization that these partnerships are supposed to be of mutual benefits. and being open-minded to learn from each other. That's very, very important. I know that there have been concerns in many partnerships that the partnership sometimes benefit one partner other than the other. And I think one of the reasons why these things happen is that sometimes we are shy to be very open to discuss issues. Is when you hold back and not be open from the onset and make sure that there's clarity in roles, clarity in expectations. This is where the problem is. So it's very, very important that the expectations are well known by everybody and understood. The responsibilities are understood. The roles are understood. The benefits are also understood. The problem is that you start discussing now benefits, maybe saying the benefits are more skewed toward one partner when you never discuss those things and what are your expectations on the benefits. This is where the problem is. And that is why it's very, very important from the formation stage that these things are spelled out and spelled out clearly. Thank you.
Thank you, Professor Norris. I am now handing over to Dr. Glenn Galton.
Yeah, thanks, Watokwa. Okay, so can you hear me all right? Yep. Okay, we're ready for our next panel. The panel will be chaired by Billy Cima. Billy's an associate professor in the Faculty of Medicine as a family medicine doc. Hopefully you heard me talking before you. I didn't just cut in. We're introducing Billy Cima as the session chair of the next session. Billy's worked in many, many parts of Botswana, both in the, in GABs, but also in the rural settings, particularly in the Northwest District hospitals, both in and outpatient clinics, in and out of the clinics and the academic setting. Billy also, really is a wonderful example of the partnership because Billy obtained his Master of Science in Clinical Epidemiology here at Penn, led through the partnership that Robert Gross and so many, and we just had the question, of course, from Robert, that Robert and so many others have been involved in spearheading. So Billy, welcome, and I'll turn the session over to you.
Thank you very much, Dr. Galton, and thank you very much, VC, for that very inspiring talk. We really enjoyed that, and it talks to the issue of partnerships, which we are celebrating today. Welcome everybody to this part of the symposium where we go through a panel discussion. And the panel discussion this afternoon is themed Supporting and Expanding Research Capital Through Partnership. So we're going to hear a lot about research and how it is supported in the partnership that we are talking about today, the Botswana UPenn partnership. To start off, before I introduce the panelists, I would like to just share you a little bit of an overview of the research footprint of Botswana UPenn partnership. And as already mentioned, as a recipient of some of this engagement, I will talk a little bit about some of the training opportunities that this partnership has afforded those who are involved. Just as an overview, there's been over 70 training and research opportunities through this Botswana UPenn partnership. There's probably a lot more that are not documented, but we are aware of at least 70 of these. In many of these, and in majority of them, the University of Botswana has been a primary collaborator with the University of Pennsylvania and CHOP, as Dr. Galton mentioned earlier. there's been some funded training opportunities in advanced clinical research training in epidemiology and implementation science. And there's been some work done to support some of the MED residents. As you all know, that the MED program that we offer here at the School of Medicine involves some sort of a research component, which includes a dissertation. And just the engagement with some of the projects at Penn has established that support for some of the residents. I would like to briefly talk about the clinical epidemiology training, which leads to an award of the Master of Science in Clinical Epidemiology, which is a program that was funded through the D43 mechanism. And there's been two such that has benefited colleagues here in Botswana. I was part of the first one, whose PI is Dr. Robert Gross, who we had a question from just this afternoon. The clinical epidemiology training that is supported by the D43 offers really two offerings. One is a main MSce degree, which involves a 2-year training program, with the first year being spent at the University of Pennsylvania in Philadelphia, with some coursework and close mentoring, one-on-one mentoring, and development of a thesis project for that. That takes a year. And then that is followed by a second year, which is based in Botswana, where the recipient then implements the project. By the time that they leave Penn, they should have their MSc project approved through the IRBs. So when they come to Botswana, they start on the data collection or the analysis if they're doing secondary data analysis. There's ongoing support during the second year, where there's a weekly mentoring session through video conferencing, and sometimes there's an opportunity for in-person when the mentors come, or there's conferences that the MSc fellow gets an opportunity to attend. The second offering is the Associate Investigator program, which is a longitudinal training program for those who are interested in a research capacity and who are seen to be able to support the MSc fellows, as well as others who are in this research space. This is offered through a workshop-based program that will involve people from across the country. Really, we had people attend some of these workshops. And this is an interactive training program. The week is really based on a curriculum that involves all the key components of research. And it's really hands-on with presentations from different aspects and getting yourself involved with some of the understanding of the research methodologies and data analysis components. Really exciting program that we've seen some interest from people across the country. The MSce program, which aims to develop independent investigators, is really targeted to people who then, following this training, would launch an independent career in research. And usually these are people with a background of medicine, registered nursing, some other advanced degrees have been involved with the training. The key component is that they should come back to a research position. And the trainees usually come from the University of Botswana, and that is just a natural way of launching somebody's research career. And some will come from the Ministry of Health, but there has to be a commitment that there will be protected time, that the person will spend at least 40% of that time doing research, so that they complete the thesis in the second year of the training. So far, there's been 4 graduates who attained the degree from the University of Pennsylvania through this support. And there's been some others. There's funding support that came through for one of the recipients who had an NIH supplement. I think it was about $100,000 to $150,000 US dollars to support their research, which is really which goes a long way in supporting research, especially in Botswana. There's been 3 others who attained a certificate of training following engagement with the program, and there's others who are still in the pipeline and will come out from there. I did mention the associate investigator training, and I said it's really a didactic session where the trainees go through the main components of research, really design, some issues to do with database management and analysis, and how to critique and read a scientific paper, which the participants really find this valuable, and it's really eye-opening to attend these sessions. Beyond the MSc program, there are many other opportunities that the partnership offers that come with some funding, and most of these are pilot fund. There's a CHOP Global Health Pilot Fund, which offers up to $20,000 US dollars for a project, and the applications will be closing in about 10 days. Maybe those who are interested will consider it next time. There's also the Penn Center for AIDS Research Pilot Program, which generally would offer about $60,000 US dollars or $40,000 for a mentor pilot project. There has to be a demonstration of a partnership in these projects, where you've got a US-based investigator and a Botswana-based investigator. Unfortunately, this one has just passed, but there will be another offering coming up in the next year and the following years. Recently, the partnership is also evolved to now introduce another service that we call CDBang, as one way to suggest at the well, taking from the saying that CDBang huiwakatsela, which means we all need to walk together to reach a goal. We need to follow a certain pathway, and we believe research is like that. And this service is aimed at offering support for those early investigators, those who are struggling with getting their heads around a design concept for research or analysis component of their research. And this is aimed at providing that technical advice to mentor people through this. So this will be shortly be launched, and we hope that will even enhance this kind of collaboration and partnership. And this will be open to our UB, MET, and all junior faculty across the disciplines at UB. And as you know, interdisciplinary collaboration is well encouraged. Other research space, in the other research space, UB and Botswana UPenn partnership as a joint molecular lab, which is doing amazing work as well. We had in some of the poster session, some work done through malaria work, which is really exciting. And recently there's also a robotics lab which has been set up for rehabilitation, and we're looking forward to even more exciting outputs from some of these research-based collaboration. So we've seen a lot of projects that talk to the idea of partnerships and collaboration through this symposium, through the Botswana UPenn partnership. Our panelists that we're going to discuss this afternoon will share their own stories, how they started off in research and what sort of areas they are currently working on, and what challenges they seem to be at. How do they tackle these wicked problems as we've come to know them now, to address some of the health challenges in Botswana and possibly not just here, but globally, because research is increasingly becoming global. So we know that this partnership has facilitated this collaboration and offered mentorship, and we've seen some guidelines impact from some of the researchers, which we'll hear about through our panelists, and some of them in this panel have also seen their research career and academic career really blossom through this partnership and being offered the space that the partnership offers. So I'm excited that we'll be able to hear about these projects from our panelists. And I will start off by introducing them to you. We've got 4 panelists this afternoon. And the first panelist is Ari Ho Foster, or Ari Ho Foster, who's the Assistant Program Director in the Office of Deputy Dean for Research and Graduate Study. He's got a wealth of knowledge in research. And what's amazing about Ari is that he is well versed in both aspects and is really taking this idea of not being in a silo seriously. So he's a qualitative researcher as well as a very able quantitative researcher. So we hear a lot about the work that Ari does, and he supports some of research administration and is very much well versed. And in his prior life, he used to work for Botswana UPenn partnership, and we'll hear a little bit more about that. The next panelist is Elizabeth Laurentel, or Liz Mahobuntle, as she's also well known. Has done a lot of work in pediatric HIV in Botswana, has had an impactful career that has seen changes in some of our HIV treatment guidelines. And Liz is really, I share one thing that I'm proud of is I share a mentor with Liz, and is like a big sister to me in terms of that. Liz does a lot of work now, shifting towards neurodevelopment and cognition in children to do with HIV infection, and we'll probably hear a little bit about that. So very exciting to hear what she has to say about this partnership that she's been involved. And we have also Maemo Isiapito, who is possibly one of the most recent graduate from the MSc program, fresh out of the grueling program of the MSc. And she is based at Princess Marina and does nutrition and runs a center there for nutrition and support. And we hear a little bit about the work that Maemo does. Wonderful opportunity to see her work also takes off in a possibly non-academic setting. And we'll hear some of the challenges that she has. I should also see on the spotlight Dr. Precious Motlokwa, who is also currently completing MSCE through the same partnership through the 3 training in clinical epidemiology for HIV. Dr. Mutloka is a dentist, another clinician who is delving into research, and I'm sure she has a lot to say about the challenges that she faces in that space. So very excited about our panelists, and we look forward to hearing from them. We want to be very use our time very well, because times tends to speed up when we are having fun. I've got a number of questions that I want to engage our panelists with, but before that, I just want them to just share with us their background in terms of research and this idea of expanding research capital through partnership. How do they see that? How do they interpret that in terms of their day-to-day work in research? And what are some of the challenges that they would like to point out to us? So very excited to hear what we're going to hear from these panelists. So first up, I will, in no particular order, I'll ask Liz Laurentel to tell us how her experience has been in terms of the Botswana UPenn partnership and her own career in terms of this theme of expanding research through partnership. Has this worked for her, and what are the challenges? Liz, take it away.
Thank you. Can you hear me?
Yes, loud and clear.
So those of you who've known me a long time know that I came to Botswana in 2004 with absolutely no interest in research. At the time, I was part of the Baylor program and came really to provide clinical care and to help accelerate the rollout of antiretrovirals to children throughout the country. And I had committed to a year position, which ended up expanding into 4 years. And during that time, my husband was recruited over, he's an internist and infectious disease specialist, and was recruited to the BUP program. And he decided that he wanted to go back to the US to do more training, while my heart was still very much in Botswana. So during our last year in Botswana, I did a lot of soul searching about how can I stay connected and continue to make a difference. And I met Robert Gross and Andrew Steenhoff, who told me about the MSCE program. And I realized that a lot of the problems that we were struggling with as practitioners in Botswana in terms of not knowing what the best standard of care was for children really needed research to guide them. And so that's what really motivated me to seek training at Penn and ultimately to develop my research career based on the problems that we were encountering as practitioners in Botswana.
Great, thank you very much, Liz. Same question to our other panelists, and I just breaking news is that one of our panelists, Precious Mutlokwa, has also just attained her MSc, so congratulations, Precious. Ari, how has things been in terms of building partnerships and research capital? What are the challenges that you come from the era of, administration, seeing research administered through the BUP office and collaborating with UB collaborators and Ministry of Health, and I'm sure you will have something to say about the challenges there.
Thank you, Prof. Cima. It's been a fascinating shift, having spent 8+ years with the BUP program, and then having the good fortune of being able to join colleagues at UB. I think there are tremendous strengths through the partnership that UB and the government of Botswana have benefited from, and I think, having been on both sides, that there have been tremendous gains both with all parties. And I would say probably the challenge, I think, is one of maintaining communication and understanding. I think that a lot of that, as there's so many successes around where that has happened, and where our growing, emerging investigators like yourself have benefited tremendously. And I think that these virtues that have been mentioned by our VC today, and of mutual respect through partnership, are key facets of that. Yeah, I think from the administration side, that is an area that I'm also learning to traverse, and that there are differences in culture and opportunities to develop between our institutions, that I think that will help to synergize both UB as a partner to Botswana UPenn partnership, and vice versa. And sorry, one last one. The opportunity. We talked about it a bit yesterday. The opportunity of maximizing, optimizing. I'm speaking to you from the teaching hospital, and what a tremendous opportunity that is for us to collaborate. And so, yeah, that's challenges but opportunities.
Thank you very much. And just a reminder to all our audience that you can also, if you have any suggestions for questions or follow up, please just type it up for us so that we can react to that. Mayemo, so you are working in a very busy referral hospital, and you come with advanced clinical research training. How do you find that the balance between your day-to-day clinical demands, as well as the need to launch your research career? How do you do that?
You can hear me, right?
Yes.
I think that is the most challenging part, especially in the past year because of COVID. Because when you are working in a clinical area, it is patients first and everything else after. And that was the greatest challenge. So, but because, of maintaining the relationships that we have with our mentors, so once in a while you'll ask a question and then they'll kind of give you pointers on how to handle things. But at the end of the day, look at it from this point of view that yes, it's important that you prioritize your patients, but the research you're also doing is also beneficial for them. So don't look at it as if you are neglecting them by doing your research, but negotiate with your employers, negotiate with your supervisors, that they will eventually understand that at the end of the day, you are like advancing the science of nutrition. And I remember this particular statement Gross said to me. He said, it is good to think about everything else, but learn how to communicate so that you don't find yourself feeling like you are trapped to not be able to do any research, but learn how to communicate. But balancing it for the past year, it was difficult, but it worked out because also COVID, it came with a bit of benefits because of the lockdowns and the isolation. Sometimes we use that for research. So at least for the past year, it has worked well. I believe that's what also helped me to be able to graduate, because otherwise time is always the main challenge. Thank you.
Wonderful. Thank you very much, Mayemo. The next question I have is for Precious. Now, Precious, what excites you most about research and its impact in Botswana? You, as a new graduate, you must be very excited about opportunities for research, but what excites you most about its impact?
Being a new investigator, really, that's quite exciting. But to be honest, it's not something that, in the beginning I was excited about. Gross will tell you that starting the course, I was just excited about going to US and, going to Las Vegas. But, like Maima said, with the relationship that we have with our mentors, they kind of steer you, in the right direction, and you start to develop that interest, develop that love, also looking at the passion that they have for research. It kind of just, they implant it on you somehow. So, looking at, dental in Botswana, oral health in general in Botswana, it's a virgin mine for research. It's one of those areas that have not been touched. And to me, it's fascinating to be the first one to start, digging something and actually going to people and see, here's some evidence that, I have come up with what the practices that we are doing, So it's very fascinating for me that, I will be making the biggest impact in oral health. And, I'm just hoping that we'll continue until we get to University of Botswana, where, oral health will be part of, a faculty in UB. So I'm really excited with the research, and, I feel that's, something, sometimes you don't have to do the biggest things. You can start in your little corner. And for me, this is my little corner to start in excelling oral health in Botswana. And it's just fascinating for me.
Wonderful. Thank you very much. That's very interesting to hear. Maybe I want to go back to Maemo, and maybe Liz can also chip in this. This idea of mentoring. How does it? What are the dynamics now that you've got a partnership? Where do you look for mentors? Where and how do you work with a mentor in a partnership when the mentor is based in the US and all that? How does that work? Maema?
The availability of internet and online services really makes it possible, even though there are quite a lot of challenges. You know that sometimes I'll be trying to be in a meeting with her and I'll be falling off the meeting over and over because of the unstable internet that I'll be using. But for me, having a mentor, I look at it this way, because when I first started my career as a professional, I desired to do research. But then along the way, I realized that research is very systematic and it has its own principles, it has its own governing protocols and stuff. So, and doing a wrong research can really be harmful, either to one's career and also to whoever the results you brought out is supposed to be applied to. So then I started checking out of doing research, because I was like, how do I know I've done the right thing? And that's when I started looking for opportunities, and BUP one materialized. But for me, it serves as more like a safety net. Because when you are still early in your research life, you don't want to be making gross mistakes. But when you have a mentor, especially mentors who are very advanced in their own professional. So at the end of the day, you know that even if I make a gross mistake, somehow they'll pick it and they'll raise it up that we think here, this particular part of the protocol or this your hotline is off. So that helps me to have that assurance that I shouldn't be afraid now. I shouldn't be afraid to do research, because I know there will be somebody who will pick it up if there is a problem. So that really works very well for me. But communicating, we maintained a plan on how, especially the second year, like we meet every week. And then from there, we meet every week, but we schedule meetings and then we meet as and when we need that. But most of what I do, I will always forward it to her, because, because it's a safety net. So I need the safety net to make sure that what I've put down makes sense. So it really works for me from that point of view.
Great. Liz, do you want to chip in there, being a mentor as well?
Sure. I think that sitting here as both a mentor to Maemo and the mentee originally to Robert, gives me a perspective of how I've tried to keep the same rigor that I had here sitting in Philadelphia once my mentee went back. And one of the things that I think is really powerful about the MSCE program is that the mentors really are expected to sit down face-to-face in pre-COVID times, at least, with their mentees for an hour every week, plus a lot of other interactions in between. And so you really get to know that person, and you get to know what motivates them, how they think, and how you can best help them. And it's hard when people go back and their clinical work and their lives are pulling them in a lot of different directions, but really working to maintain that relationship, I think, is the key to success, just like relationships in general, I think, are the key to success in any long-term project. So I think Mayamo and I are doing okay, but she gets pulled away a lot, so it's challenging.
Yeah, no, that's the reality. Thank you very much for sharing, both of you. Let me move on to Ari and ask this question, and this question also I'll ask all of you to maybe chip in as well. But Ari, I want you to start off here. We heard from the VC that there are certain problems, wicked problems, and healthcare is that area where we have complex problems that we need to solve somehow. And doing research, I think, can also be seen as that complex problem, and depending where you start off. So if you could make one or two changes in the infrastructure for research in Botswana, what would it be, and how do you think that change could help? Ari?
Thank you. I think I just also wanted to chip in on this mentor.
Yeah, please go ahead.
Dynamic, because I think that is part of an important part of the solution in terms of infrastructure. What I've come to recognize in recent years is that there are incredibly strong mentorship dynamics, like the ones that have generated these graduates from the MSCE program. And I think that the next level that would really support us as junior investigators within Botswana is mentorship around collaborative team. And as we become more increasingly, I think I actually don't know many research problems that are solved by individuals. There's so many collaborative teams that are transdisciplinary. There is, I feel there's a gap in how junior researchers appreciate and utilize trainees and how they become mentors to the next generation of mentees. I mean, Dr. Laurentel, you are tremendous in your delivery of that, but I think that is where one of the areas, and I picked up also from Dr. Makima's idea yesterday as well, about the idea of postdocs and the importance of postdocs. That is a gap that is, I think those of you who have gone through clinical training in specialist areas see how there is this depth of increasing independence that you witness when you enter into a specialty program, and when you come out as a engage at more and more senior, more and more independent levels, but one witnesses that. And I think that there'd be benefit in having, one, the capacity that fills in those gaps, to having a greater range of trainees, and within research, I think that's what we're, one of the infrastructure things I think support for greater opportunities for postdocs within our space. Yeah, those are two of the main.
Great. That's great. Anyone in the panel as well? Do you have any thoughts around that same question on what infrastructural changes or ideas you'd change to make research more workable for you in Botswana? And how do you think that could help? If you were to change anything, if you had no budgetary constraints, no wicked problem issues.
Okay. All right. Thank you for that, Billy. You know, that's one thing that I've just been thinking about. You find that, yes, BUP has stronger partnerships with UB because it's an academic institution. But, you know, now looking from the past years that you have people like me, people like Maemo, and we also have people like Olorato Matiba, you know, also from dental. Now we are having more people in a government setting, in a non-academic institution that, you know, maybe we should try to look at ways on how can we tap into, you know, Ministry of Health, into government, you know, for them to start recognizing research. Like Mayama said, you know, it's only at a level of me and my supervisor. It doesn't go as far as the ministry to say, you know, if you have this degree and you're interested in research, you know, we can give you so much protected time to do research. You know, I think that would be beneficial, and you have something to support it with as BUP to say, you know, we have produced so much and they are in your setting. And from my side, you'll find that I do love hospital dentistry. I enjoy working there. And we still don't have that opportunity in University of Botswana. We don't have a faculty yet in University of Botswana to say, I can move to University of Botswana so that I can be able to do more research. But, you know, I think government is not that rigid. I think if we can start tapping more into the government to say, you know, how can we cultivate what you already have in terms of research, you know, especially in terms of protected time, even though an increase in salary will be nice, but.
Right.
Time, it'll be a good start off point, to be honest. Thank you.
Wonderful. Thank you. Thank you for that reaction, please.
Yeah, I really wanted to make the same point about protected time. And one of the things that's really challenging when we're collaborating with great people in Botswana is that when they're working for organizations like UB and the Ministry of Health who pay 100% of their salary, even if they want to have part of their salary and covered and their time protected under a grant that we're applying for, the mechanisms right now don't allow that. They can't go to UB and say, okay, if we get this grant, I need 30% more protected time and the grant will pay for that. So I think that as there's more coverage for those individuals for their other duties, more clinical graduates, more teaching graduates, there'll be more flexibility for that. But I think it's something that really needs to be prioritized for these people who have fabulous training and drive towards research to be able to actualize their potential and mentor the next generation.
Yeah, and those are really internationally recognized, you know, standard of practice, you know, good practice, which I think is an area for growth for us as a new institution. And I think the Faculty of Medicine is probably a step ahead with the leadership of the Dean and Deputy Dean for Research, who has set up an office that really is trying to address some of these issues. And Ari is working on a day-to-day basis with investigators who are trying to really have that understanding, the funding mechanism, how it supports your effort and all that. It still needs to be institutionalized, and there are challenges, but I think we've made great strides. Two excellent questions that I want us to address in the chat. One I saw earlier was from Andrew Stenoff, and the question was, can you comment on the perception of research in Botswana from the UB government and community perspective? Perhaps, is there an appetite for appreciation of and desire for research? Great question, I thought. So we don't have anyone here on the panel from UB. We do have Ari Horfoster here. So this is a great question that I like our panelists to address. Panelists, anyone? What are your thoughts around the perception for research? Great question.
I think I would like to say this one from a junior investigator and also from a member of the Institution Review Board for Marina. You'll find that even in government, sitting in a review board, you'll find that it's something that you have to do in your own spare time. And looking at Marina is one of the heart of research, of medical research. You find we have, loads of research that's being done there, but, you'll find that you are not even given time, as review board to be, reviewing proposals, to be checking study sites, see if everything is done according to how it was proposed, to follow up on things. So you'll find that research is still very much lagging behind. Same thing, at least of recent, the Ministry of Health has started the research body. So I'm not sure how far it is now, but it is we are making baby steps, but I think it's still very much left behind. And I think, UB, because they are more academic, I think they are at a better, stand to advocate with the ministry on how can we improve research.
Great. Mayemo has?
I originally wanted to add on to the protected time situation, but then I thought to myself that, me and Precious, we are probably the two public servants who are still with public service, even after this training. Maybe we could just find a way of making sure that we inform beyond our supervisors. We go beyond, just like we do in all other areas of our professional lives. When working conditions are not good for us, we normally ask for audience somewhere upstairs. Upstairs meaning in our ministry. So maybe that's something that we could look into, so that at the end of the day, we know we have done our part, rather than just dying in silence. I think that's the right way of putting it. Yeah. Regarding the perception of research in Botswana, this one is a bit tricky. I'm a public servant, so in public service today, we know our government is saying they want a knowledge-based economy, and based on that, somebody would say we could look at this as a window of opportunity if it can materialize. Look at this as a window of opportunity to say, okay, now that this is what government wants to do, now we come in and say, as researchers, we know that you do really need the evidence for you to be able to achieve some of the things you want to achieve. So maybe, because every single thing in life is a window of opportunity. So maybe this is a window of opportunity to now engage our leadership more, so that the perception of research especially in the public service, because that's where you have a lot of people. You have a lot of public servants, and if a lot of them could have some kind of protected time, they could be trained, they could be capacitated, there is a possibility that we can actually generate much, much more research than we are doing right now.
Wonderful. And just to read what one of the comments from Professor Masire, she says, it is also beneficial for UB to advocate for research colleagues in government ministries, which addresses the issue that Precious and Mayemo are raising. And she says, we are working towards protected time, which is a bone of contention that we've been discussing. Protected time at UB for colleagues with grant support, which I think best international practice would be wonderful, and it's good to see us moving towards that. Did you have any additions to the perception of research in Botswana, Ari, from whatever perspective?
I think there has been an important recognition of the need for information. We've just come out of the, well, we're still in COVID, the pandemic, but they're pre March 2020. I don't recall seeing so many PowerPoint presentations on a weekly basis and showing graphs and charts. So as a tool for communicating in the response, I think that's there's a lot of dividends from past research and past external funding that's supported research infrastructure through where would be we without PEPFAR. But I think the perception and maybe this is a dated one, I recall the days when evidence-based planning was something that was talked about, and people would talk about EBP. They wouldn't even say evidence-based planning because there was a training that had gone through higher senior levels of public service. And some of that I think can be picked upon and we can come back to seeing how it can benefit and be recognized by ministries. In terms of internal mechanisms, we would love to see a national research fund. I think we talk about this a lot at UB, and that there's we see to the south of us, or in South Africa, we even have a couple of our faculty that have been supported through indirectly through some of these sorts of awards, and we need that to support our research in Botswana. I don't think we've moved much in terms of trying to get the US to increase their 4 and 8% cap on overheads, but that is certainly one that has moved in other countries. The UK in the last 2 years has increased its LMIC offering to LMIC institutions, so it would be that would be a useful thing for the partnership to advocate for that, because I think that as a stronger partner through those sorts of overhead supports that can help us to develop infrastructure.
Wonderful, and you've actually tapped onto the other question that I wanted the panelists to address, from Glenn Galton, who says, parallel to Andrew's question, are there appropriate funding mechanisms in country to support the growth in the research base, or will the dependence be external? If the latter, this of course requires different types of orientation to the projects to be competitive. Your thoughts, panelists? Research funding.
What was the question again, Billy?
So the question is, are there appropriate funding mechanisms in country? So can you access research funding in Botswana?
I think it's limited. Yes.
There is. Oh, sorry.
No, go ahead.
Go ahead.
As far as I know, there's no research fund. And I remember there was a time I went to ask the research unit, why can't they make that part of the mandate? And they were not able to give me like a clear answer on how to go about. The only opportunities that would be there would be like, say, maybe somebody is funding government for a particular project, and then they want preliminary assessment to be done. That's when they can make a call, and then people can apply. But other than that, there is no research fund which we can within the government or national which we can directly access on it.
Yeah. And any additions there? It's a resounding limited and no funding. And that really raises the begs the question of where do researchers based in Botswana access research funding independently? being prime recipients, and how easy do you think that is? And I think maybe Mayamo and Precious are maybe early in their career to have tried, but I'm sure you are thinking about it. And you know, maybe I ask Liz this question: how competitive is the research space out there? I mean, most funding from the US comes from National Institutes of Health, the CDC, and other funds. There's other independent ones like Bill Gates, and Bill and Melinda. I hope they're still Bill and Melinda Gates Foundation. And you know, it's a tough world out there. And Rich, Ari will also testify how many proposals come through his office by investigators from the faculty that are successful. And just to say how difficult is it to get external funding, and do you think the partnerships support this, and how have they helped?
So funding is obviously highly competitive, especially larger funding sources like NIH. But the advantage that we have as partners is that there is some really unique infrastructure and some really unique patient populations to be able to answer questions within Botswana in ways that frankly would be much more expensive, if even possible, elsewhere. An example of that is in pediatric HIV. If I were to try to enroll 300 children in a study in the United States of children living with HIV, it probably wouldn't be possible. And if it were possible, it would require probably dozens of different clinical sites spread across the entire country, and would be orders of magnitude more expensive than a single site study could be in Botswana, where you have entities that are caring for thousands of children and adolescents living with HIV. So these are questions that are generalizable to children throughout the world, but that could really uniquely be done in sub-Saharan African settings. So yes, it's highly competitive, but I think that Botswana is primed to be competitive to answer those questions, the questions that are relevant to your own people.
Right. We've run out of time, and we just scratched the surface here, and that just shows how this area is of interest and really useful. So I'm just going to give our panelists just 10 seconds to just have a parting shot for our audience. I just received a message that we can go for an extra 5 minutes, which is great, because I think you are itching to comment my panelists on the issue of funding. Ari, I directed a question.
Yes. Sorry. Yeah, I just wanted to add to Dr. Laurentel's comment that I think that the other wonderful thing about doing research in Botswana is stability. And hearing this during the experiences reflected from Fogarty-supported grants in other LMICs and the challenges has put Botswana in a very, very enviable position as a stable place to carry out research, and kudos to the governments in sustaining that. I think the other we're trying as my deputy dean often reminds me, our office is very new and is underfunded. The faculty has it's very competitive. As Dr. Laurentel had said, in 1 year, I think there were fewer than 10% of applications were funded, but and I hear that the NIH statistic is something like 8%, and I just it's we completely appreciate and benefit from senior mentorship and that's innovation and collaboration through partnerships like this. So this is another reason for giving thanks.
Yeah, exactly. And you know, some of my unfunded work, if you get comments that are very complimentary about the environment, because you know, in a situation that the Faculty of Medicine UB offers, the infrastructure is world class, and you know, we just need to work on certain things that will make us competitive, even more competitive. I think that element is well addressed. The innovation and the approach, I think that's what needs to develop possibly. But even the infrastructure that we have here at UB, I think it's really speaks volumes to what we can do. And maybe to end on a positive note, to all our panelists, how would you encourage others who are trying to get into this partnership and research capital? How do you? What's your advice to them in getting them staying on and progressing through, you know, some of your, maybe even get to some of your achievements? How would you encourage that young new investigator who is looking at tapping into this partnership?
I would say to them, if you really love research, then the earlier you join, the better. And it will also serve as a safety net in the first years of doing research. So yeah, the program can be really tough. I remember when we were doing our MSc, the pressures after that, we looked back and we were like, we can't believe what just really happened to us. But at the end of the day, there's a lot of support. So somehow, you'll be able to make it. It might be tough, but somehow you'll be able to make it. But if you really, really love research, then it is best you just follow through and then best. And when it's a partnership like that, because it also comes with a bit of fund for research. So the first research, your second research, you are not stopped by lack of funds. At least there'll be funds for you to do that. Good startup for you.
Thank you very much. We have run out of time. Just because I feel that we're leaving it hanging. 10 seconds to say bye. Liz, Precious, and Ari, you've been a great panelist. Just your last 10 seconds to say bye.
Okay, thank you, Billy. I just want to say thank you to the UP partnership, and I'm looking to actually grow into research with them, you know, work hand in hand till we can apply for our own grants, you know, open the Faculty of Dentistry here in Botswana together with them, and, you know, creating those milestones. Thank you.
Thank you very much. Ari and Liz, 10 seconds.
Thank you, BUP. I think that, it had tremendous impact on my career. I think those based at Penn interested in engaging in the partnership, utilize the local office, utilize the BUP has that tremendous advantage of having a local office in country who can help connect you with the investigators here, or to understand who to connect with and to navigate. Thank you.
Thank you, Ari. Liz, last word.
I just want to thank Botswana for letting me continue to grow my career alongside you. And in terms of mentorship, just to make the the point that it shouldn't be a short-term commitment, that I think mentors become families, just like you're now my brother, Billy, and Maimo, I guess, is your niece.
Yes.
You know, I think we need to stick together as a community and support each other, not just for a year or two, but for our careers.
Thank you very much. Thank you very much. Thank you, panelists. Thank you, audience. Back to you, Len. Sorry for taking 2 minutes over.
Not a problem. Fabulous panel. You know, all of this speaks to, and I put a comment in the chat about this, something that even at a research institution with as long a history as we have here at Penn in research, how the faculty are structured and how the support systems are brought together to support them, both their time in the university, the funding for their research, the size and growth of the faculty and where they're positioned. I think one of the real advantages that you have, I mean, you don't have something like, we have the NIH, et cetera. You don't have that, but what you have that we don't have is a ministry of health and wellness that's very, very focused on delivering improved healthcare for the citizens. So particularly for the faculty of medicine and us as your collaborators in this space, tying the projects directly to the ministry's objectives, I think is an advantage that you have for thinking about, different ways of funding projects that we just simply don't have here in the United States, not really having a ministry that's as directly involved since our healthcare is essentially privatized, with the exception of the Veterans Administration. But fabulous conversation. Long-term mentorship is the key always. We should be lifelong colleagues, as Liz said. Very, very well said, Liz. So back to you, Watokwa, with no introduction for the next panel, which I'm really, really looking forward to hearing the wonderful stories of people's lives and how they've been changed by the relationship.
Okay, good afternoon again, colleagues. So we now looking at the future, how we nurture the next generation of leaders and change agents in the healthcare system. Now, yesterday we had the privilege of hearing from one of our young faculty and her passionate call for opportunities to be trained as leaders. Although she obviously appreciated her training, her technical training as a clinician, as a pediatric nephrologist, but now coming home to try and start a service, she realized just how much she needed to be trained of how to lead herself, how to lead a team, how to establish a system that functions, which is really speaks to the soft but very important aspects of being a successful clinician. Now, the other thing that she strongly advocated was, yeah, we need more specialist clinicians, but and importantly, that we need to train the whole team. And very often as healthcare professionals, when we're thinking of a team, we're thinking of the doctor and the nurse and maybe the lab, the lab scientists and maybe the radiographer. But a functioning healthcare system needs a lot more than that. We need people who know how money works. We need people who know how to make things work, how to ensure things are there when they should be there. And so I have the privilege this afternoon to introduce a team of young professionals who are not all healthcare workers, but are important ingredients in a health and in an optimally functioning healthcare system. And so I am going to introduce this afternoon Dr. Keneilwe Motlatledi, who is now a lecturer in the Department of Family Medicine and Public Health based in Maung. And Dr. Motlatledi has been working with Professor Kancheda in the primary healthcare program, the rural primary healthcare program. And she's also hopefully finishing her MSc in epidemiology soon. And then we also have Dr. Masheto wasn't able to attend this afternoon, but we also have Dr. Mukumani, who's a senior lecturer in the Faculty of Health Sciences in the medical lab sciences. And we also have a medical student, Dr. Ngwaku, and also medical student at the Faculty of Medicine. And then also we have Mayor Podiso Tirelezo, who is the Director of Finance and Human Resource. These are usually the members of the team that when we think of health system, we forget about, but are so key to us, to our success. So I'm going to give each of them 5 minutes to tell us about themselves and their broadly about themselves, their relationship with PEN, their mentorship, and what is working, what's not working. And then we'll take it from there. So we'll start with Dr. Mukumani.
Okay, good morning, good afternoon, everyone. I think I've already been introduced. Maybe I need to just go straight into my story. Yes, I'm a senior lecturer in the School of Allied Health Professions and the Faculty of Health Sciences here at the University of Botswana. I have a BSc in Clinical Lab Sciences from Howard University.
I don't think we can hear Margaret.
Can you hear me now?
We can hear you.
Okay, yeah, I said I have a BSc in Clinical Lab Sciences from Howard University in Washington, DC. I also have a master's in clinical microbiology from Griffith University in Australia. And I have a PhD in medical science, which I obtained here at the University of Botswana. In terms of my work experience, I worked previously as a microbiologist at the National Health Lab under the Ministry of Health for 23 years. And during my time there, I think I built both institutional and national capacity in microbiology diagnostics and surveillance. I actually worked with some colleagues from McMaster University in Canada to develop an in-house multiplex PCR assay for detection of enteric pathogens in Botswana, an assay which I used for my PhD. Again, together with colleagues from BUP, I helped establish the National Rotavirus Surveillance Program in Botswana after the introduction of the vaccine. And then in 2019, I joined the University of Botswana because I believe that I could use my experience to train, up and coming scientists, as well as maybe to venture a little bit more into research. For me, the opportunity to do a PhD actually came because of my relationship or my collaboration with BUP. At the time, BUP already had a collaboration with the Ministry of Health and of course NHL, where I was working at the time. But my personal relationship with BUP started during the time, when I met Dr. Andrew Steenhoff, who was by then the director of BUP, country director. So I worked with him on numerous projects, one of which led me to my very first international conference where I had to go and present some of the work that we had done here. So then in 2011, Dr. Steenhoff introduced me to Dr. David Goldfarb, who would later on become a great mentor to me and also my supervisor for my PhD. At the time, Dr. Goldfarb has actually secured a grant from Grand Challenges Canada to do a study on gastroenteritis in Botswana. So it was through this project that I was able to do my PhD. But also throughout my PhD studies, I continued to receive a lot of support from BUP. I received support to go and visit McMaster University, to go and visit CDC in Atlanta, to learn some of the techniques that I actually used for my PhD. So, and personally, I believe that I have actually grown as a researcher through my, relation, as a researcher and an author, through my relationship with BUP. I have participated in some of the most impactful research projects through this collaboration. And I think of note, and one that I'm most proud of, is that when we embarked in the gastroenteritis study in 2011, it was during the time when, as a country, we were going through a diarrhea outbreak. So our findings from testing some of those samples actually provided some valuable data, which actually assisted the Ministry of Health to introduce the rotavirus vaccine. I've also met and worked with a lot of colleagues from BUP, and I've done a lot of research with them. As a result, I'm proud to say I've actually authored and co-authored about 26 publications, and it is all because of the work that I did with BUP and I continue to do with BUP. I've also, done a little presentations to report some of the findings from some of our research projects. So I was representing, our group of collaborators or group of researchers from BUP. I've been able to go and present in Geneva and through a number of, other African and international rotavirus conferences. So I think maybe I'll stop here, but just maybe I would like to, okay, maybe I'll stop here for now. I think I'll say some of the things later.
Oh, sorry. Sorry, Dr. Mukumani, I just wanted to say thank you. Thank you so much for the presentation. That's quite a lot that you presented. Dr. Mutlakledi.
Thank you, Prof. Nkomazana, and good morning and good afternoon to everybody. My name is Kinelo Mutlakledi. I'm a lecturer at the University of Botswana Family Medicine and the second year an MSCE fellow at UPenn under the D43 funding. I did my undergraduate training at the University of Ghana in Accra, and I obtained my master's in family medicine from the University of Botswana. I was one of the first graduates from the University of Botswana and a fellow of the Colleges of Family Physicians of South Africa. I've also completed the East African Diploma in Tropical Medicine and Hygiene. Since graduating from the University of Ghana, I worked in Botswana at Princess Marina and then at Sabrana Psychiatric Hospital. Then I did my family medicine training at the Mahalape Training Complex. After I completed my family medicine training, which I started in 2011 and completed in 2016, then I had a short stint at Princess Marina before I got placed, where I was at the cervical cancer screening unit with Professor Masire, that was also under UPenn. And I think just as a bit of background, when I came into medicine, I wanted to do psychiatry, but that's why I was placed in Sabrana Psychiatric Hospital. Then for a while, I thought I missed the other parts of medicine, and I had some friends who were doing family medicine, and also family medicine doesn't have a lot of hospital care. So that made sense to me. So I branched from psychiatry into family medicine. And I've always had really been driven by a love for my country and for, I think, the people in Botswana. And to me, I think about Botswana and a lot that was said yesterday and today, and I don't see why we can't be the leaders in healthcare. So I think that's one of the things that drives me. And that's one of the things that I really like about the partnerships that the country is making, the ministry is making, and universities making with BUP and other such institutions. So I then went into becoming a lecturer in family medicine because I'm hoping that I will be able to contribute towards this quality healthcare that we all dream about. I'd like to say also here that Professor Nkomazana also was very instrumental in me becoming a lecturer, because I used to think I couldn't do it. And then she was like, well, you have to try and there'll be support around you. And there really has been a lot of support in that sense. So in terms of me and BUP, when we graduated from medical school and started internship, there were BUP personnel in Marina working mainly at internal medicine and pediatrics. And they supported our internship. There were lecturers there who were working with us. There were also students from UPenn who used to come and we would interact with them. And that was really helpful in terms of internship and in terms of thinking broadly about medicine and what the possibilities were. They also had like journal clubs that we used to attend. I think most of them were run by BUP. And then during my residency, when I was in Mahalape, we had medical internists and pediatricians who used to come out to Mahalape to support our learning and also to support the care of patients there. And it was through this that I met Dr. Jackie Firth, who was one of the physicians that used to come out to Mahalape. And we developed a relationship, and she then became my co-supervisor for my research. And that was really helpful. And she's continued to be a mentor even after I graduated. And then recently, I've started working with Professor Kansheda on a community-oriented primary care project in the Ngami district where I'm now placed. The project is a collaboration between the district health management team in Ngami, the Department of Family Medicine and Public Health at UB, and BUP. And how it came about was that we had been talking about community-oriented primary care in the department and trying to come up with a proposal. And at the same time, Dr. Kibabonye, who's also here, was also thinking about how to advance public health and primary health care in Botswana. So we got to talking, and she was also placed in Ngami district at the time. And Prof. Corrado came out, I think, to Maung at the time, and his talk inspired us, and we talked to him after that and explained our idea to him of having this system of primary health care that was really oriented towards and directed by the community. And he was really game and joined in. And so we started developing the proposal. And it really aims to enhance primary health care by bringing together communities and the service providers. And we're leveraging on existing structures to deliver the high quality, relevant, and acceptable primary health care using innovative techniques, and also thinking about creating a database for every community so that everybody has a medical home. So really, I think that as an MSc fellow, which I joined last year, and I'm now into my second year, through where the principal investigator for the D43 that I'm in for trauma and injury sciences, Professor Weep, and my primary mentor is Professor John Holmes. This has also been a very eye-opening endeavor for me, because as part of UB, we're expected to supervise and to also supervise postgraduates when they're doing their research, and also to conduct their research. And I felt a lot inadequate in that part. And I think Prof. Cima, who encouraged me to join the D43 training program. And it has been a wonderful year and a half where I've learned a lot. And I think there's now a lot for me to give back to the residents who I supervise and also to the country. So I think that in all, for me, BUP, ever since I started working, I've worked with them, and I've grown with BUP. And I'm hoping that they have also garnered something from the interactions with me. I cannot name all the people that I've worked with through BUP. Hopefully I haven't left out too many people. But I think in terms of what could happen, or maybe I should stop here and then we'll see what goes on. The other questions there. Yeah, okay. Thank you very much. Prof. Nkomazana, you're muted.
Thank you very much. Oh, okay, I get excited and I start talking. It's an all-women panel, imagine that. So now we're going to hear from Ngwaku, and I apologize that I said a he before when I talked about you. So please go ahead.
Okay, thank you. Good afternoon. My name is Ngwaku, and I'm a fourth-year medical student at the University of Botswana, and I'm also the president of the University of Botswana Medical Student Association and the class rep for my class, which is fourth year. So I'm from Bobono, and I'm a second born at home. So I'll talk about my story of how I became part of BUP. So I'm a cancer survivor. So I joined medical school in 2018. And on my first semester, I got diagnosed with retinoblastoma. And then I had to go do surgery in South Africa. So when I came back, while I was in South Africa, I was with other people who were there for surgery, mostly who had cancer like myself. So when I came back, I met Dr. Pologolo and I told him that I have interest in doing research. I have interest in cancer and mostly pediatric oncology. So I expressed my interest on that area to him. And then he introduced me to Dr. Marion Brooks. I think at that point she was looking for someone to help with research. And then he told me to get in touch with her. That time I get an opportunity to do something there. So that's how I met Dr. Brooks from BUP. So since then I've been doing researches with her, mostly being a research assistant, with some having co-authored some of the papers with her. And then, yeah, that's basically it, how I met Dr. Brooks from BUP. And then she took me under her wings to be her mentee. And then she trained me. I got to do some courses. I did refresher course for research under the CT program. And then she also introduced me to Dr. Jonathan, who I recently started helping him in his research, I think a month ago. So that's how I've been part of BUP, mostly as a mentee under the mentors there. So moving on to my personal achievement. So I want to believe that I was always a brilliant child growing up. So I was part of the top achievers when I was doing my junior certificate exams. And in my senior school, I went to China to represent the country for Math Olympiads. And then I went to Ethiopia also for the Science Olympiad as well. And last year I was involved in a research in surgery with Prof. Tapley, where I had to do a presentation for the Global Surgery Symposium, which was held in Nigeria. And in 2019, I was awarded the Golden Key Society for being the top 15% in the university. And that automatically made me a Golden Key Society alumni, where I continue to be under that mentorship as well. And then on my special skills, I am good with writing, which also I've managed to nurture through working with Dr. Marion Brooks, because she managed to allow me to do some of literature review, writing, methodology, sections of a research paper to be specific, and research proposal. So I'm a writer, and I plan on maybe writing a book about my story once I'm older or I'm done with school. And also, I think some of the things that I managed to realize about myself is time management. Being involved in a lot of things allowed me to nurture my time management skills, because I'm a student. I also have to go home. I also need to do research. I need to also spend time with myself. So time management has my skills for time management. And also one thing that have also helped me build good relationship with my mentors is the ability to show up to commitments, show up when people invest their efforts on me. So that is why I'm grateful. So I'm full of gratitude for everything that I've managed to experience under Dr. Brooks and Dr. Jonathan. And then my future aspirations, I think I've mentioned them. I want to be a pediatric oncologist. I think it's mostly inspired by what I went through. Initially, I wanted to be a surgeon. I wanted to do general surgery. However, with what happened to me, my vision hasn't been that well. So I felt like surgery was out of the picture. And also having had my rotation in peds and also seeing what was happening at the hematology and oncology ward, I felt like that is something that I would be happy to do. Because also when I was there, I had experience with moms who had who their kids had retinoblastoma, and I told them my story that I'm actually here. It was my 3rd year anniversary with my prosthetic eye, I think last week. So I told them I could encourage them. So I felt like it was gonna be like a very great place for me to be once I'm done with school, and possibly being able to specialize in that area. And yeah, that's basically it about me. So I'm hopeful that I'll continue working with people from BUP, meet other people, because to be honest, I only knew a few, Dr. Marion Brooks, Dr. Jonathan, and others. So I intend to interact with a lot more, to learn a lot more. And yes, thank you.
Wow, 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 wow. I'm already intimidated by you now. Well done, well done. So the next presenter will be Podiso Tsireletso.
Thank you so much, Dr. Watokwa. I've already been introduced. Yes, my name is Podiso Tsireletso. I'm a Director of Finance and HR Operations. I have a diploma in accounting and business studies from the University of Botswana and a Bachelor of Accountancy from the University of Botswana. And I'm currently doing my Master's in Business Administration with the University of Botswana, in which I'm waiting for the results for my thesis. So I'm looking forward to completing my, my Master's. My journey with BUP, I take it as a beautiful journey, because when I joined BUP, it was in 2012, you know, 2 months after I completed my undergrad. You know, I was called by the internship office, and then they said, we found you a host organization. They call themselves the University of Pencil, the University of what? The officer then, he couldn't pronounce the University of Pennsylvania. And he ended up saying, oh, but the other names here include Botswana. They're saying Botswana Youth and Partner. I don't know what this means. I don't know where they are. So I got a little bit shocked to say, but why am I hosted in an organization that, you know, the office doesn't know, you know, they don't know where they are located, you know. And then he then called the office, and then they said, oh, we are based in the University of Botswana, and then we have another office along Independence Avenue. Okay, interesting now. So I had to start the following day, actually. So the following day I come to work, and when I got here, you know, I had been a University of Botswana student, always passing by the porter cabins, but I never saw Botswana Youth and Partnership. So it was just that day, you know, my first step in the University of Pennsylvania. And believe it or not, the atmosphere, the welcome, it was so amazing. So I started as a government intern, and before even 6 months, I was promoted to be a finance assistant, you know. And then to me, that was just incredible, because the welcome to UPenn was so great that actually my boss, which is Mr. Ariho Foster, and my immediate boss then was Mrs. Mpiwa Mwate. They welcomed me into the office, and I remember the first day when I joined, I was given an assignment, and I was very excited. So yes, the first week was just so amazing, you know, and I felt like BUP was the right match. You know, me and BUP made the right match. We, you know, I just loved BUP the first week when I started. So it was after a year when I was then promoted to a finance officer. I would like to say that my boss then, you know, for some reason, he gave me the opportunity to apply myself, you know, and I enjoyed working with him, you know. So in 2020, I was then promoted to the Director of Finance and HR Operations. To me, this was a great achievement. And I still feel like I still have an interest, you know, in in long-term commitment with working with BUP, because with my current role, it's a very interesting post. It's a very, with interesting roles, and I'm looking forward to continue working with BUP. And I can see that with the role, with the post that I'm in, you know, there is a room for growth, and there is a room for continue developing myself professionally and personally. So to me, when I talk about BUP, I know I haven't worked anywhere before, but you know, even at this day, I still feel like it's like I just joined BUP yesterday, but I have 9 years working for Botswana UPenn Partnership. And I'm very excited to say that, you know, I was listening to Dr. Billy Cima, you know, giving that brief overview of the MSCE programs that BUP is doing. And I'm glad, because I do play a role in that, you know, in terms of finance and HR, you know. And it's so amazing that a lot of people, the MSCE trainees, some of them are graduating. It's very important. This is a very good complementary and good feedback to our operations team, to say that, you know, the support that they are giving, not only to our employees, but even to our partners, even to our trainees, it goes a long way. I'm glad that I just heard that Dr. Precious has just graduated. Once again, congratulations, Precious. We're so happy that we've been part of your journey as a trainee. We've supported you. We've supported Dr. Gineile, Dr. Mukumani. I've worked with them. I've worked with Dr. Billy. I've worked with so many of them from UB. And believe me, we've never treated them differently from our staff. We treat them the same way, you know. Every time when they come in, you know, we orientate them. And I've received a good feedback from them, especially our partners. They always give me a feedback to say that, you know what, it's the first time we see an organization that is so organized. You know, when you need money timely, you will get the money well on time. And that is the way that we have been trained by Mr. Ari Hoffoster. I still remember him. I always remember the way he mentored me, you know. So the acknowledgement goes to Mr. Ari, it goes to Dr. Doreen Ramokola. These are the people who, you know, made me believe in myself. Like I say, all the accomplishment that I got, it was through their leadership. And yeah, I can say a lot, but for now, I'll stop here. Thank you.
Thank you, everyone. Wow, what inspiring stories. I'm looking to see if there are any questions from the audience. But as we wait for questions from the audience, I just want to say, I note that you all have had different experiences of mentorship, some deliberate and formal, some along the way. So if you were sitting at the table today, or you were invited to sit at the table where UB and UPenn we're planning on a mentoring program for people like yourselves at all your different levels, what would you want to see in the menu? What would be maybe one or two? I think each of you can answer that. What would be important to you that should be part of that menu? I'm going to start with Margaret Mukumani, because you were the first to speak, so maybe you had a bit more time listening. But anyone can start if you're still thinking. Can you unmute Dr. Mukumani?
Sorry, okay, sorry. Yes, I think from my experience with the mentorship that I received, I think the most important thing is for somebody to actually give you their time. I mean, I was getting this mentorship from people that I knew. They were very, very, very busy, but they always had that time for me when I needed them. For example, Dr. Goldfarb, for the whole duration of my PhD, he was actually based in Canada, although he would come here maybe once or twice a year. But I knew that he was always an email away. He made time such that even if I needed to run maybe some presentation through him, he will always be there. He will make that time. It will take, either an hour, 30 minutes, I'll be going through a presentation. So, I mean, you really need to have the assurance from your mentor that they'll always be there for you. They'll always make sure that they give you time whenever you needed it. I think that's one of the most important things that I think they really worked for me.
Great, thank you. Dr. Mutlatledi.
Thank you. I think just to echo what Dr. Mukumani said, I think time and having dedicated time, like really reserving time and having it been routine. What I've learned with the MSCE is that we all know, and there's a set time with everybody that everybody has with their mentor, like every week at 3 p.m. I know on Wednesdays I'm meeting my mentor, and sometimes it's just a general sort of talk. How are you? What's your career plan? And sometimes it's very specific to the MSCE. Then I think also having definite targets out of the mentorship, like what outcome would you like to have out of this mentorship? When would we say this was a successful mentorship? I think also for me, recognition, I've come to realize that maybe it's a cultural thing or maybe it's just a me thing. It's difficult for me to approach somebody and say, can you be my mentor? And I think we miss a lot of opportunities there. So in the beginning, I think it has to be an intentional thing, identifying people and saying, you will be mentored by this person, but also having the flexibility to say, can I go to Yehoda and say, Yehoda, would you be my mentor because I'm interested in this that you're doing? Yeah.
Thank you. Wow, do you mind putting on your video as well if you have a stable internet, and take that for us?
Okay, thank you. I'll just add on what they said also. Opportunity to be afforded the time so that she could learn. I think I was privileged to be mentored by Dr. Brooks because she was kind of busy. She had a lot of projects that she was working on. So that gave me an opportunity to learn hands-on. I remember she would be saying, I want you to work on a section of a research, this section. And sometimes we're like, I don't know, she's like, just try anything, and then I'll come and look at the work. So she gave me time in the sense that when I first started, I didn't know so much. I was still young also. So I didn't have like vast knowledge on research on how to write it. So she gave me an opportunity to apply myself. So I think maybe as a mentors could like do that, allow their mentees to engage themselves. If they make mistakes, they could try to correct. And also maybe as much as she was mentoring me more on the research, she also was very kind and caring towards like everything that concerned me. So if I was struggling with school, I could actually let her know, even though she might not like tell me surgery stuff or family medicine stuff, but she would just be supportive. She was she afforded me the opportunity to actually be free to let her know what exactly was going on with me. And that allowed me to be productive in like the work that I was doing with her. So I think the time and just giving an opportunity for the mentee to apply themselves and see how far they can go.
Wow, thank you. Emma Mesirelezo.
It looks like time is a very important factor here, and I'm going to talk about time also. Like I said, my mentor, Mr. Arihal Foster, at any given time in a day, he will create time for me. there were times where he will see that I haven't moved from my office to the kitchen because his door, when I go to the kitchen, I had to pass through his door. And he will kind of wait and see if I've ever gone to the kitchen. And if he sees that I've been in the office for a long time, he will just come from my office and say, "Hi, Podiso, how are you doing? How is everything going?" And then he will start, we will start talking and talking. So I think time is very important here when it comes to mentorship. And the other thing that I will point out is communication skills. This is one of the elements that I learned from my mentor. Mr. Ari will write a very long email. I'll sit down and read it and sometimes even highlight it to try and understand where it's coming from and what he wants. And to me, what I learned was not just because I can talk, it means I'm a good communicator, but this is where I learned to communicate, to really understand the message that I'm trying to put across to another person. How much information will that person need? So this is something that I really learned from my mentor. And this is what I'm also even trying to pass through to my subordinates to say, you know what, when you write an email, make sure that the other person will understand what you are saying. If it means even giving an example, please do so, because communication barrier can stop everything. So yeah, for me, time and communication skills have made me to grow to a person that I am right now. Thank you.
Fantastic. Thank you so much. I think we do have a 5 minutes. So now I'm going to ask this one. No matter where you are, somebody's looking up to you. So you either deliberately or by accident, you are mentoring someone. So what do you see as your role in mentoring those that are looking up to you? And what, having benefited from mentorship, what are you doing or going to do to ensure that there's a generation after you that's also being mentored? Anyone can start. That includes Mao as well. I'm sure a lot of medical students, even other people, are looking up to you thinking, wow, I'm already thinking I can learn 1 or 2 things from you.
Okay, I'll start. I think, as I said, for me, I started in the clinical area. I only joined the university like 2 years ago. And I think one of the reasons that I already mentioned was just to make sure that I impart my skills on the new generation of scientists. That includes also, venturing into research, because I think it has already been alluded to by the previous speakers in the previous panel, that, when you are out there in the clinical area, you don't have so much time. Like people are talking about protected time, you don't have such kind of things there. But I just felt like maybe here I'll have a bit of time to be able to do some research. In fact, currently I'm actually the research coordinator in my school. So I'm actually sort of working with a lot of currently mostly undergraduate students. I'm supervising quite a number of them. I now have a PhD student. I'm encouraging even my former colleagues to actually enroll for graduate studies. And I have some who have started enrolling into MPhil, some they want to go on into PhDs. I mean, I would really like to see, and they always ask me, will you be our supervisor? I'm always willing to do that. And I'll be always tell them that I'll be very, very happy to supervise them so that they achieve what I have achieved, because I believe it's doable. I did my PhD as a part-time student. It wasn't easy because I had to juggle, my studies, my work, my family life. But because I had so much support from my colleagues from BUP, even from UB, I had a very good supervisor in my dean, Professor Ishmael Kasusu. So you really need to have a very good team of supervisors, or people who will handhold you all the way, because it's a challenging journey, especially if you are doing it part-time. But I think this is what I'm willing to do to my fellow former colleagues, my fellow Botswana, to encourage them and to support them in actually taking their graduate studies. So I think
thank you. Thank you, Dr. Mukumani. Let's just be brief.
Okay, I'll go next. What I can say to those who are looking up to me, you know, here at BUP is that, especially the operations team, is that, you know, I'm an accountant, and what I knew was debit and credit. But when I got to BUP, I started hearing jargons of medical, you know, terms, you know, but that, you know, cultivated an interest to me, you know, to say, now I've entered a different zone. I'm going to learn a lot. So I learned a lot from the scientists. I remember Dr. Mukumani has just mentioned the rotavirus in 2012. When I joined BUP in 2012, there was a rotavirus in country. And at that time, I was expecting my second born. You know, the fact that there was a study about rotavirus within BUP, which was led by Dr. Andrew Steenhoff, Dr. Tonya. You know, I used to stand with Dr. Tonya in the corridors just to ask her, what is going on? What does this mean? So I learned a lot from the science space. One other thing that I can say to those who are looking up to me is to say that, hey, continue developing yourself. Self-development is very important. Don't just say, oh, now I'm working, I'm earning salary, I can do 1, 2, 3, 4. Personal development is very crucial. So, yes.
Thank you. I think for me, it's one, trying to develop relationships that are beyond just a supervisor and a supervisee, create an environment where the people that I think I'm mentoring feel free to talk to me about things that are bothering them, even outside the scope of medicine, but also always trying to talk to them about, but where do you see yourself? Where do you want to go, and how are you going to get there? Because I think once you understand where somebody wants to go, it's easy to help them identify the tools that they need. And also through other relationships and other mentorships that I have, I'm able to identify if somebody maybe is interested in orthopedics, I can say, okay, let me link you up to this person who's also in orthopedics. So also finding opportunities that are relevant to the people that I am mentoring, I think is something that I try to do.
And then,
okay, I'll just briefly. So with me, I believe in showing up. I think that's one thing that has helped me. So even when I talk to my juniors or just my colleagues, I always encourage them to show up. One thing I've noticed with mentors is that you find that they're not only mentoring me or you, they usually have like a lot of students or a lot of people that they're mentoring. So the important thing is to always show up, because then you show interest, so they're more willing to help you, because also you are putting in the work. So you might need to follow up on them sometimes to be like, can we please have a meeting? So I think also as a mentee, you need to be able to be in that position to show up, be in that position to be like, I want to do this, please help me. I'll be consistent and committed to this thing. Because I think that's what helped me.
Well done. Thank you, ladies. I think I'm going to hand over back to Glenn. What an amazing group of young women you all are. Thank you. Glenn, are you taking over?
Yeah, I'm here. I'm freezing, however. I'm in an older building. You keep wondering why I'm putting more and more clothes on because there is no heat in our building. I'm talking about institutional resources. The older buildings at Penn, they haven't shifted the heating over yet, and it's freezing here. I had my mask on before just to keep warm, not from any infectious agents. Well, that was a fabulous session. You know, it's just inspiring, frankly, to see the impact that we've had, not just with the scientists, but with the whole community in so many different ways. So congratulations to everyone, and thanks for sharing your stories. I'm going to turn it now over to the BUP director, Corrado Cancheda, and Corrado doesn't need an introduction to anyone. Let me just simply say, I met Corrado, oh my gosh, Corrado, how long ago was it? Maybe 6-7 years ago, something like that, at a dinner.
Yeah, it was 5 years ago.
5 years ago at a dinner hosted by Larry Shulman, who had known and met Corrado. Larry was then at the Dana-Farber and had been working with Partners in Health, and Larry continues now at Penn to lead the oncology program under the broader umbrella of Partners, but as part of Penn now up in Rwanda. And some of you know Larry because he's also been a mentor to Yehuda and Serbia and others working in Botswana. And I met Corrado and Edith, his wife, at dinner, and just frankly fell in love with his vision for global health. Corrado had been working previously with Larry and others in Partners and other organizations, has a long history working on the global health space. Corrado's trained, as many of you know, as an infectious disease specialist, but frankly, his passion is really all about building sustainable delivery systems that work for the local environments. And it's really with this perspective that he's approached his directorship at BUP. And that as you'll hear from him, and I think a little later, Miriam, the vision of how we're moving forward the next 10, 20 years for BUP and how we're thinking about the relationships between our institutions and what we hope through our conversations with you will best serve the citizens in the country of Botswana. So Corrado, thanks again for your leadership, for organizing the symposia, and I'll turn everything over to you.
Thank you so much, Glenn, for a wonderful introduction. I have to say, impossible act to follow because the panel discussion before was like amazing, really, really amazing, inspiring, inspiring people that it was just really, really moving. So we'll talk about the strategic planning process for BUP. I won't do it by myself. I will do it with Miriam Brooks, who I'm delighted to have as the new director for pediatrics and research. She just started a few months ago. Before she was one of the top global health fellows. She's a pediatrician who also has a subspecialty in adolescent medicine. And she's just a wonderful partner to work with. Really, really blessed to have her on board. Welcome, Marian. So without further ado, because also we're running a little bit late, I'm going to share the screen. I'm going to inactivate the video and share the screen. And we'll keep this very short. All right, so we'll talk a little about the strategic planning process for BUP, right? Because as we look forward, how can we channel even more all this amazing talent that we've heard from, all this passion, this commitment to the health of people in Botswana, to the health of people around the world, to be honest. So we thought we should try maybe together collectively to think 3-5 years ahead, to sort of set the direction that we all want to pursue together. So I've shown this slide yesterday, just to sort of capture where we're at, because the strategic planning process is really like a tangible way to get into the details of how we're going to move things forward. We started 20 years ago with the HIV pandemic. This was the time of the Millennium Development Goals, the Global Fund, and PEPFAR kicked in, and we were able to scale up HIV treatment under the leadership of the Ministry of Health and Wellness. Then they took ownership beautifully of the HIV program. We started focusing on other diseases like NCDs, because that's where the priorities were. Then COVID-19 hit, and where do we take things from here? How can we really make an impact going forward as the situation evolves? And again, it's not just BUP that's going through transition. It's global health as a whole, right? It started with tropical medicine, which again does not have like a great legacy. It moved to international health. These were the years of the Almata Declaration, the great vaccination campaigns, and then it really started with global health after Cold War with the HIV/AIDS pandemic. And now that a lot of things have happened, starting with the Great Recession, climate change, and the COVID pandemic, where is the field going, and how can BUP be part of defining where the field is going? So we tried to ask ourselves the question a couple of years ago when we did our first strategic planning process, and we came up with the answer that maybe one thing where we really want to be particular is like the way we partner, almost independently of whether we do HIV or tuberculosis or cancer or pediatrics. What is it about the way that we partner that is different? Then we thought, partnerships can really be not just a way to get things done together, but to transform institutions and organizations that participate in them, so that they're even better equipped going forward to take the challenges that we'll have to face. And of course, we also want to continue doing things differently. So whether that means taking on a new programmatic area or moving to a new geographic area. So, this graph is basically to make the point that we're really here to serve. The idea is that really through BUP, we serve the priorities of the organizations that are part of it. And the most important priorities, that's why there's the huge circle, is of our partners in Botswana, Vision 2036, the Ministry of Health, University of Botswana. Of course, the priorities of PEN, but also the priorities of the world. That's why the SDGs are there, because the idea is that what we do here is truly relevant, not just to Botswana or the US, but to the world, and that the Ministry of Health and Wellness, University of Botswana, and PEN are not just local institutions, they're really global institutions. The impact that they have is a global impact. So we have a bit of a theory of change, go through this quickly, but the idea is that, if we partner as PEN with our wonderful partners in Botswana, and we really live up to these ideals of equity, accountability, empathy that the Vice Chancellor actually talked beautifully and eloquently about earlier. Yes, we'll be able to implement projects and advance health, but we'll also, I think, hopefully both us and our partners be better off at the end of the project, so that we can even implement projects independently of one another, and maybe even partner with other organizations to scale up what we do in other geographical areas, and maybe even change those institutions for the better, right? Almost like a ripple effect. And we changed a little bit our mission statement to sort of capture this renewed vision. So that's why it says improving health in Botswana and beyond through the power of partnership. So I'll stop here. I will let Marianne continue with the next slides. And so Marianne, activate your mic, and I will inactivate my mic. I will move the slide.
Cool. Next slide. So the next part of this presentation is about the fact that the process of strategic planning has already started for BUP. And so we have some goals that we have sort of established that we really want to move forward and think about the ways in which these particular goals can be expanded with all of our partners and within the institution. Next slide. So the first set, the strategic goals that were established by the group with Corrado's facilitation are what you see here. So our initial strategic goals are improve access, coverage, quality, and safety of health services delivered. So the key part of that is health service delivery. And being a part of the quality improvement process in health service delivery. So what I love about this particular goal is that it's not just about, meeting a research outcome and hoping that after the data are out that something will happen with it, but rather we're doing some translation work that will directly impact patient care. Strengthening capacity in Botswana, that is something that, you know, all of the partners do, and we just want to make sure it's upfront. I actually prefer the term professional development to capacity building, because we're all starting as professionals and we really want to get ourselves to the next level. So doing capacity building or professional development is about making sure that we as partners can help programs to be sustained. Also developing people at Penn. So remembering that Philadelphia is a very underserved community, that Penn has its own legacies that need to be overcome. And so how do we use the lessons that we've learned from our partners to teach Penn how to be better partners in the world and for the local community? We also want to obviously generate and disseminate knowledge. So that's where the research comes in centrally, but also is going to be related to strategic goal number 1, and then improving the effectiveness or quality of partnerships. And I really like how Dr. Vice Chancellor Norris really mentioned about the quality of partnerships and actually laid out what I think is a roadmap for creating quality partnerships. That's also a part of our strategic goals, and it will really help for us to be overlapping with that. Next slide. So
Sorry, I'm having some trouble.
It's okay.
Oh. There you go.
So how will we know that these strategic goals are being met? So for strategic goal 1, some examples of metrics of success would be health indicators. And this is where I think our Penn partners, our UB partners, our intellectual powerhouses can really help us to measure this. And that's actually measuring health indicators as a part of our work. So oftentimes with research, we see that there are only certain kinds of outcomes that are supported or appreciated, but often many health indicators are relevant and haven't been established in all the populations of Botswana. So looking at those health indicators, seeing if the programs that we're doing are moving those needles will be vital. We might also check things like the number of patients accessing a health service or things like that. In terms of goal number 2, we might measure the number of students trained or mentored. And this is something I know the Center for Global Health at Penn is really interested in, and really strengthening that program and actually taking stock of how many folks are being trained and mentored, expanding that training program, and making sure that we have processes in place to make sure that those programs are meeting the needs of both sides of the partnership. Strengthening capacity at UPenn is also related to training and mentoring, but is also, we might measure how their processes change as a result of our influence. Next slide, please. So for metric 4, for strategic plan 4, we would want to look at the things that we always look at: impact factor of publications. And one of the other things that's not listed here, but that's also important, is actually getting the information out to local stakeholders so that they can do some of that translational work of putting the data into practice. And then for strategic plan 5, improving the effectiveness or quality of partnerships, we would want to look at whether there's fair distribution of benefits, establishing joint planning, again, as Vice Chancellor Norris mentioned, making sure that we are working together with our strategic plans so that our overlaps are just enough and that our respect is ideal. Next slide, please. So our goal for the strategic planning after the symposium is to, in the next few weeks, and identify with key stakeholders. Thankfully, many of them are here today, many of you are attendees. So we'll identify those key stakeholders, create some working groups so that we can, again, try to fulfill some of that high quality partnership that Vice Chancellor Norris mentioned by actually listening to each other and being at the same table. Next year, we would like to use these individual working groups to try to build upon the strategic plan with input from our partners. And we want them to be a part of these working groups, but we also don't want to overburden them. So we want to make sure we strike that good balance. And then early in next year, we'd like to consolidate those different working groups into a master plan. And by next year, around this time, we'll have another retreat and continue to identify priorities so that the strategic planning process is iterative and responsive to the needs of the times. Next slide. So overall, the whole point of this is to make sure that we are not moving forward in a vacuum and that we can make sure that our goals are being met. So we'll make sure that we are actually measuring them and continuing to create goals that are measurable and making sure that we're lining them up with the goals of our partners. Next slide. So overall, the most important thing to get from this presentation is that we are committed to having a well-rounded program, and we are committed to high quality, respectful, equitable, thoughtful partnerships. And we aren't always gonna get it right, but we're gonna work really hard to make sure that we are thoughtful and pushing ourselves to be the kind of organization that continues to work well for the country. And one of those ways that we are, working is by expanding our work beyond Gaborone to the Okavango Delta region, and looking for stakeholders there to continue to be committed partners there. And so overall, I hope that you all will continue to partner with us and continue to push us to be better partners so that 20 years from now, when we're having the 40-year anniversary, we can look back fondly on the progress that we've made.
Thank you so much, Marian. And I may add, maybe 20 years from now, we'll all be working together in another country to support their health system. Who knows? So now we have the panel discussion, which I'm really, really excited about and that I will be moderating. So thank you, Marianne. So I will introduce the panelists. We're running a little late, so I'm going to ask that we won't finish at 11:45. We'll finish at 11:55. I hope it's okay with all the attendees, because really we have a powerhouse. We have a dream team of panelists, and I really want to do them justice. So we start with Dr. Malebogo Kebabonya Pusoensi, who is Senior Consultant for Primary Healthcare at the Ministry of Health and Wellness. She and I actually go back a couple of years, I would say, when I actually went to Maun. She was the DHMT Director. And, she and I and Kenelwe, we sort of found this common passion for primary healthcare and rural health and like reaching communities in needs. Since then, she actually became Director of Health Services at the Ministry of Health and Wellness, and now she's in charge of primary healthcare, and we're just really excited to have her on the panel, and I know she will give us a great insight on primary healthcare and rural health in Botswana. So welcome, Dr. Malebogo. The second panelist is Professor Ismail Kasfosve. He is the Dean of the Faculty of Health Sciences at the University of Botswana, a long-term partner of, really a long-term partner of BUP. It's been investigator, co-investigator, PI, like on a lot of like research projects. Just a wonderful person to work with. He's also worked really, really close, in particular with Dr. Giacomo Paganotti, who sort of manages the lab center that UB runs both at the Faculty of Health Sciences and of Medicine together with BUP. And Professor Kasvosve will actually talk about future directions for health research. So welcome, Professor Kasvosve, on the panel. We're delighted to have you. The third panelist is another professor, Emeritus Professor Wallace Miller. So he is actually from Penn originally. I think he did both his MD and his residency in radiology at Penn. Became really like an institution within the institution, known really as a master clinician and educator. He's mentored countless medical students and residents and fellows at Penn. And then I think he was lured out of retirement. I remember he and I were talking when he was in Spain by our other panelist, Dr. Mosepele, to come to Botswana and run the center, basically be the chair of the Department of Radiology. So he will talk about future directions for radiology. And then last but not least, we are going to have Dr. Mosepele, who has a medical degree in Australia. Then he did his residency in medicine at Penn. So there's like this institutional affiliation with Penn. Then he moved to Harvard, and I think he and I crossed paths a little bit when I was there. He did his ID fellowship there. He also did a master in epidemiology there. And he returned to Botswana, which of course is wonderful. Was the chair of the Department of Medicine. He recently stepped down of that position. He we're still running the Presidential Task Force for COVID-19. Again, another wonderful partner, incredibly accomplished person, and just an honor to have him on the panel. So thank you for everyone. Thank you everyone for being here. So I will start with the questions, and I'll go in the order of introduction, I guess. So the first question is actually for Dr. Malebogo. So can you just like paint for us like a picture of the current state of primary healthcare and rural health in Botswana in terms of like health service deliveries, in terms of health services available? How good is access, quality of care, these sorts of things? Thank you.
Thank you very much, Corrado, and very well. Good morning to the colleagues in the US, and it's quite good afternoon to the colleagues here in Botswana. And thank you for the introduction. I won't go that much. To answer on your question, this is just to, yesterday I had Dr. Majani define himself as the dinosaur of pediatrics, and I felt I was given the opportunity to talk on a subject that is mightier than I and has been led by the likes of Dr. Magani for quite a long time. So if I have to talk to the primary healthcare in Botswana, primary healthcare, everybody will know and acknowledge that Botswana as a country long took the decision, or the strategic decision, that we aligned to the alma mater of the 1978 and quite recent, even with the revitalization of primary health. So that has been the anchoring roadmap for how healthcare service delivery is supposed to be in Botswana. We have moved from the situation where there was no doctor, and our healthcare system was primarily led by the nurses. And we also had a cadre that used to be called the family welfare educators, that is the commonly known as the FWE. And these were the cadres that for primary health, and to just, it's a note or a reminder, and I know that talking to people who know, you know that primary health is quite rooted to community participation and being able to deliver the right healthcare service to the right community at the time when they accepted or anticipate to have such kind of a healthcare service. So this is how we started off planning, or how Botswana has planned its delivery of the healthcare service, that it should be, it should start from the root or from the grassroots, that is from the communities, and be relevant at the community level. The CADA FWE was introduced as more kind of an advocacy or a linkage of the community. And this CADA FWE, they were not non-medic, but and chosen by the community themselves. And these were actually a linkage between the structured, or what you say, the healthcare system as we know it, and the community. And they were meant to advocate for all things that are possible at community level and link the healthcare system with that. This CADA has since moved on to now being recognized as the health education assistants, or the HEAR, that we know, and they continue doing the same thing. So accessibility of healthcare in Botswana can be defined as quite good, and we're one of those that boast. And if you look at some of the indicators, and this will be the communities that are living within a certain radius, in which we use 8-kilometer radius of the healthcare system, and that as a country we are around 95%. And we further do, and you know that in primary health, the indicator on maternal health and the under 5 mortality has been used mainly as a dipstick on how the primary health care is doing. And this is mainly because it gives you an idea of the participatory of the community. But if you look at women accessing, or women who are able to deliver in the assistance of a healthcare worker, for that indicator, we are at 97%. And this says that at least there is that good participation by the community. And if you look on the under 5, and we go further down on the indicators of primary health, and this will look on the high impact intervention, and this will look at the participation in the child welfare clinics. And this is the mothers bringing their children consistently for 5 years to at least benefit from your growth monitoring, getting vaccinations, and and the like, and support. And for that also, the country's at least performing at around over 80%. And this still shows that there is, if you talk primary health on its eternity, especially if you're looking at community participation, these are some of the things that we can look and reflect onto. But I don't know if I'll be preempting my next question, Corrado, but to say that these are the traditional primary health as everybody else have known it. But we now know that for now, primary health is looking onto the challenges that are coming with the changing dynamics of the community. We know that we are seeing the rapid changes, or the when we see the rapid urbanization, we see the aging communities, and we even see that communities are becoming more educated. Primary health started off with its main effort. I know that when I read back on public health and primary health, I continually see the WASH, and that was what defined primary health. And this was water and sanitation, which was, the epitome and what defined good healthcare system, or the good health outcome. So now you see that, we have moved to attaining such, or at least securing that. So now communities are getting educated, communities are having more high expectation of the healthcare, or what they need the healthcare service to give them. And this is now where primary healthcare needs to adapt to this change that we are seeing globally, and it's not only in Botswana. We are seeing that the populations are aging. The health issues, they have shifted from being predominantly communicable to now we are seeing the complexities that comes with non-communicable diseases, and overall the lifestyle diseases. So these are the things that are now adding more into the healthcare system. And when we look in primary health now deeper, we are now starting to look on the complexities of health, where we are now looking on its sustainability and the financing, and even the system that is operating this healthcare service delivery to it. So I take that I'll continue talking more onto that, but in essence, I'll say Botswana is right on its track towards delivering the primary health care as outlined in the alma mater, and even in the new declarations that I'm trying to rack my mind. I think it's a brain freeze, but I'll remember it. Thank you very much.
Thank you, Dr. Mana. It was super interesting. Alma Ata was such an amazing visionary document that unfortunately was a little derailed by separate agendas for a good 20, 30 years, but hopefully we're back on track. So the next person that I wanted to ask the question to is Professor Kasvozve. So for you, the question is a little different. Could you paint a little bit like a landscape of health research currently? What are the greatest areas of inquiry currently being pursued? What diseases or health priorities they address? And what kind of research is it primarily? Is it like basic science, clinical, epidemiological? I think that would like set up the discussion well then to explore what are things that we should be studying but are not studying yet. Thank you very much, Professor.
Yeah, thank you, Corrado. I may also have Professor Musipele as part of the panelists, so I think that if I miss anything, he'll also jump in and add onto that. Yes, my understanding of my understanding and my also research on what is happening in terms of research landscape in Botswana. I think from the outset, we would have to understand that because the research requires funding, the funding also has been driving the research agenda that has been also happening in Botswana. And this, I think, is not unique to Botswana, but I think it's commonplace elsewhere. But my observation is most of the research has been around communicable diseases, HIV, AIDS, TB, and lately, of course, we're now having a lot of activity on research around COVID-19, which is exciting. But we also have had, some ongoing research as well around non-communicable diseases, around cancer. And I think that there's been quite significant work done around cervical cancer. And that work continues to go on. I think there are some members who are maybe here, who are also part of the community of University of Botswana, who have been working in that area and doing an excellent job. And some of their research has been very impactful. But we are also starting to see research around the neglected tropical diseases as well. Schistosomiasis, research around that area is also starting to happen as well. And of course, as we know that, the next epidemic is going to be around non-communicable diseases. We're also starting to see inroads around research around diabetes and also such similar diseases as well. What is also exciting at this time is also the improvement, in my view, in technology and technology being cheaper, especially around the study of host as well as pathogen genome. And this has brought about exciting challenges or opportunities going forward. And we're starting to see some research around that area. There's been some work that has been done or currently ongoing about trying to understand the genetics of TB and HIV. And I think the group led by Dr. Matsaba at Baylor has also been doing some wonderful work of which I'm part of, and that is also exciting. So I think that in terms of, is it basic? Is it clinical? I think it's a mixture of all of those. I think there's quite some significant basic science research going on. Also, have had some clinical work going on, especially around clinical trials. Botswana Harvard partnership is well known for clinical trials, and they've been doing some exciting and good work as well for the country. But also epidemiological surveys have also been happening. Implementation science, I think that is happening, but I'm not so certain about what extent that is happening, because sometimes some of it doesn't find its way or expression in public literature. So on the whole, I think that, just as an outline, that's how I would try and describe the landscape. And I think we can go deeper in subsequent discussions. But also, I think that Professor Musipele can also chip in if I did leave something out.
Musipele, please feel free to, Dr. Musipele, please feel free to.
Thank you very much, Corrado, and very good afternoon to everyone attending. I think Prof covered everything. I don't think I can think of anything that he left out. Thanks.
Right, so the next question is actually for Professor Miller, Wally Miller. And it's a similar question to the one that I asked to Dr. Malebogo. You know, with radiology, what is the current landscape in terms of health service delivery? What health services are available? What health services are not available? Hopefully will be available soon. Just paint a picture for us. I think it will be incredibly informative.
Thank you very much, Corrado, and thank you for including me in the panel. So unlike family medicine and primary care, radiology is basically in its infancy in Botswana. So there are a total of about 12 radiologists in all of Botswana, and 85 radiographers. And it's my estimation that we need about a total of 100 radiologists and 400 radiographers available. And so in fact, medical imaging is, well, let's say this, there's plenty of machines in Botswana. So there are X-ray machines all around the country. There's sonography machines all around the country, but there's very few people to read them. And so in fact, the shortage is actually really in personnel, not so much in actual equipment, although the more advanced equipment, things like CTs and MRIs are limited. And so as a consequence, most plain films are read by primary care physicians. And actually in my personal experience already, only being here a few months, well, I think the primary care physicians are doing as best as they can. They're not, you know, optimally trained to read those exams, and there are things that are being missed. And then for the advanced modalities, things like CT, they're only available in 4 public hospitals across Botswana. And in some of those hospitals, there's nobody to read them. So again, basically, medical imaging is really at the beginnings of things right now. And so it's actually a very exciting time for medical imaging, because I think there are going to be changes that are happening very shortly in the future. I guess that's probably all I should say right now, and we'll talk about some things some more.
Thank you very much. Dr. Mosipele, and I guess the question for you is also the same, but in terms of medical subspecialties, and you know, know that Botswana has a wonderful residency program, Master of Medicine program in internal medicine. But what about subspecialty care? What kind of health services are currently available? Where in the country are available? Because you know, one thing is if they're available in Gaborone or Francistown, but not elsewhere. Again, just if we could get like a sort of a 10,000 feet view, that would be incredibly helpful.
Thank you very much, Corrado. You know, at the moment, we have very limited subspecialty care, and I think to speak to what Prof. Miller was saying, to really have those advanced subspecialties, you need support from others, imaging, and you know, diagnostics and pathology. And for as long as those are still limited and not widely available, it really limits the practice in subspecialty medicine. At the moment, most of the subspecialists in this country will be mainly in Gaborone. An increasing number of them, or a large number of them, are in private practice between Sidilega and Bokamoso, and a few between UB and Princess Marina Hospital. They're probably slightly larger group, and a group that's probably gonna soon be, you know, have the largest number of subspecialists is nephrology. We've had a few graduates from medicine go back and do nephrology. I think endocrine is growing as a subspecialty. We've just had, I think, the first Botswana come back from the US, who's a specialist in endocrinology. Cardiology, we now have 2 Botswana in private practice who are cardiologists, infectious diseases, not to tout and praise my subspecialty, is growing because in addition to the 2 Botswana who are practicing here, there is 2 more who are doing an ID, 1 at Penn and one at one of the Harvard hospitals at Beth Israel. So I think there's a few that will grow. Others, we're probably looking at 1 person, gastroenterology, we're looking at 2 people, hematology looking at 1. So again, it's very early days in the area of subspecialties, and one that we need to look at creatively and see how it can facilitate the commissioning of a place like Seki Tumile and support general programs. So an exciting space, but one that we need to work on. Thank you.
Thank you so much. Really, really helpful, really informative. I will ask another round of questions, but I would also encourage the attendees to take advantage of our wonderful panelists. And so if you have questions, you put them in the chat and I will read them out loud on your behalf. Dr. Malebogo, so we talked about the current situation with primary healthcare. I would say, what are the biggest gaps and what is currently being done to address them? And also, like, what's the role of a partner like BUP, for example, in advancing the field? I guess it's really 3 questions.
The biggest gaps of in primary health. Access to care remain one of the gap that exists, and access to care can be seen in different aspects. One, I know that normally we would look at access to care as the issue of having a hospital or a clinic in the vicinity, but access to care is deeper to what is even contained within that clinic, and if it meets the actual needs of that community. And in many a times, communities that stands or those that stands to suffer more usually will be, I'll say, the forgotten communities or the far too rich communities, because I know that currently we do have mobile stops, and these mobile stops are part of the strategy in Botswana, wherever they are. They continue to enjoy, access to care without having to get out of pocket. But these are some of the things that you then have to look into, saying what then is contained within the package that goes into the community as it is given. The other biggest challenge, and I take it that this was said by one of the colleagues in the panel, is to look at how, how primary health development has caught up with the current global development. You would realize that many a times primary health has then more kind of been looked into as your cheap kind of, and I use cheap in inverted commas, as your cheap rural kind of or infantry access to care. Whereas if you look at how the world has developed now, and how and the development that are available now within the medical field, you look at the technology that is available and the technology that is making it very easy to access communities. And if those technologies are being translated in improving primary health. And even if you look at some of the specialities that remain pretty much contained within the urban population and are not trickling down to ensure that communities everywhere or they are decentralized. And these are some of the things that if you look at primary health and you consider primary health as your first contact type of care, and what you expect communities to enjoy at their first contact. And this first contact would be both on the preventative and even on the phases of prevention. It could be secondary prevention to tertiary prevention. And these are some of the things that we tend to look into to now translate the technologies that have come with medicine and not just put it within specific areas, but translate it such that they become doable at communities. And having them doable at communities, it means we are now translating these developments together with the communities as they are developing. So I'll say these are currently the gaps that are there, where you see that when we look at the advances that has happened in the medical field, it has happened and remains within the curative sphere, and is not trickling down in order to be translated, and such that we have similar advances and investment in primary health, more so on preventative health, such that we see communities enjoying their highly attainable healthcare service. The last one, which is the gap, is the training in primary health, and having more people that can actually deliver primary health. Primary health is meant to be more of a multidisciplinary kind of approach. And we look into the community, not just on their biomedical sphere, but we also look on their psychosocial and in the environment to which they exist in. So if you look at the training, and for now, I know that if you look at the package, like I've said at the beginning, primary health in Botswana has been primarily led by your nursing cadre, and with the benefit of the health promotion cadre, and also the family welfare cadre, or the health education assistant cadre. But if you look at the medical cadres and their specialization in primary health care, we recently introduced the family physician, which is an upcoming specialty that is meant to improve that first contact access. That is the generalist who are supposed to improve that first contact. And if you look at the public health specialist as well, public health specialists who are supposed to then translate and map the delivery of healthcare services within defined communities. If you look at how they are, and for now in Botswana, we have 18 districts that are functioning for Botswana. But if you look at the number of public health specialists that are actually men in these districts, I know that currently of the 18, we have only managed to have about 8 who have the resident public health specialists. And if you look at the family physicians, I don't know much about the numbers, but from practice, I know that these are not entirely available within the country to form your basis of that first contact, highly trained individuals. So we still need to get there. We have the family nursing practitioners, and these family nursing practitioners and the community health nurses. These are some of the critical areas that remains the gap that as we are training, because now we seem to want to train in the curative and highly subspecialized cadre, we need to also balance with the training of these community-oriented or primary health care cadres that are necessary to improve primary health. Thank you.
Thank you. Really, really exhaustive answer to the question. Very, very interesting. I see questions flooding in. Professor Kasvalsve, the question, I guess, also for you is the same. What do you see as the biggest gaps in terms of health research? And again, what is being done to address them, and what can a partner like BUP do to help the country address them?
Yes, thank you, Corrado. I think in terms of research, I would like to use the analogy of a stool with 4 legs. And I think that in order to do research, you need to have trained human capital. And not only in terms of numbers, but also in terms of expertise that resides in those human capital. So in terms of just talking about human capital, I think that the establishment of Faculty of Medicine, Faculty of Health Sciences, actually will propel research and try and make us, gain ground in terms of getting that critical mass of researchers being out there and training and conducting research. So that is one of the things that I think that in the near future, we'll start to see the impact of the graduate programs at UB in terms of contributing to research. The second leg would, of course, of this tool will be technology, access to technology. Increasingly, we are starting to have, key pieces of equipment being available, not at one place, but at various places. And I think that coordination among these facilities, I'm talking about B3, I'm talking about UB itself, I'm talking about some of the research partners, yourselves, BHP, also increases access to technology, which is critical in terms of doing research, especially if you're going to be doing more cutting edge research, like looking at host as well as pathogen genomes in order to understand diseases and also develop interventions that are appropriate and most effective. So technology is one of those things that we need to have. Of course, funding, it goes without saying, funding is critical. And most of the funding that has been driving some of the high impact research in the country has been actually from external grants. And I think that Botswana, even citizen scientists have actually benefited from partnerships with other partners in the country, yourselves, BHP, and other American universities, as well as UK universities that have a presence in the country in terms of trying to attract funding to do research in Botswana. But more still needs to be done as well. And also, if funding is also being externally driven, of course, you have the challenge that any funding core would have a particular goal, and that particular goal might not necessarily align with what is very important or critical to any country. Then the last one, which or the fourth leg I would want to say, is that is ethics. I think that there's been some investments in trying to build capacity in terms of ethics. Without ethics, we can't have research, and so we need ethics. And there have been some investments that have been done in that at the Ministry of Health level, as well as at active research institutions like UB, also at hospitals as well. They start to have local IRBs, and so that's the fourth leg as well. And I think that is becoming even more important when we talk about genomics, and so you take ethics to a higher level when you're talking about genomic studies as well. And there have been investments in that. So I think that this outlines what I would think that maybe some of the gaps that are being addressed and some of the opportunities that are there. There have been quite a number of training grants increasingly, and to mention here, the H3 Africa grant, I think has done quite a bit, not only in Botswana, but quite in a number of countries where, colleagues have won grants there. And it is to develop, capacity in terms of genomic research, and we are starting to see some of the outcome of that research. This week I was attending a young man who was defending his PhD at UB, and he was doing something interesting, trying to understand how the underlying human genome in Africans can actually modify or the cause of HIV disease in children. So that also is exciting. So there has been some investments, there's some ongoing. There have been some collaborations as well, which have resulted in mentorship. And I think I would like to mention here, you did mention it here, Corrado, when you talked about Giacomo, that such an opportunity of having Giacomo working with us as well as the Faculty of Medicine has also allowed us to have additional lab space as well as a mentor to help some of our graduate students. And we just had another PhD defending his PhD study, and he actually was developed in that lab. So these are some of the real things that are happening to close some of the gaps in terms of developing a critical mass of trained citizen scientists. I'll pause. Thank you.
Thank you very much. Question for Professor Wally Miller. Again, same thing, the main gaps, what's being done or should be done to address them, and how can BUP or like international partners more broadly be helpful?
Thank you, Corrado. I think there's actually three major gaps, but there's really one major gap, and several of the panelists have noted that. And and that's the absence of human capital. So the reality is the problem in medical imaging, and actually some of the other sort of technological specialties in Botswana, like surgery and pathology and things like that, is that there's not enough trained workers to actually practice those areas. And so that's actually the reason that I'm here in Botswana. Is my primary mission as the head of radiology is to start a radiology residency program. And the idea is that we'll train Botswana people to actually take care of all of Botswana in terms of their radiologic or their imaging needs. Similarly, there's a deficiency in radiographers, and actually Professor Kasvazve is involved in trying to start a radiographer program here in Botswana, so that again we'll have Botswana radiographers caring for the public here. So that this need for trained workers is actually probably the primary need in the sort of technological specialties of which radiology is one. In addition to actually training those people, the other critical need is actually having a platform and actually to perform that function, both to train and actually to do these advanced, or let's say these technological innovations. And that is in fact the teaching hospital, Serketa-Mili Maziri Teaching Hospital. And that is actually probably the linchpin of moving forward in those areas. I know that radiology hasn't really begun, but my sense is that surgery and pathology, and to some extent anesthesia and the medical specialties that I hope Mosipele will talk about, all are struggling because they don't have the technological platform to move forward. And that platform is here, it's SKMTH, but it has to open. And I'm hoping that that will happen very soon. The two other sort of deficiencies that are present here in Botswana are a public-private problem, where the private sector is actually quite well resourced and actually has pretty good workers to perform those functions, and the public sector is behind. And I'm hoping that the training programs will fill that gap. The other major gap is an urban versus rural gap. So the medical care that's available here in Gaborone is actually pretty good. It's getting close to the standards of the high-income countries around the world, but that's not true in the rural settings. And in order to provide at least radiologic care in the rural setting, the thing that I think we need to do is develop a teleradiology. And I'm actually working with the Ministry of Health in trying to get started what's called a PACS system, which will allow us to perform radiologic imaging in small communities, or at least bigger hospitals, but in further away from the center here, and actually provide radiologic care centrally. So anyway, the two big, and actually how can the BUP partnership help? Well, from my perspective, that's mostly going to be help in training, so that we're going to need teachers either remotely or locally that can provide training, and then maybe some technological help in terms of how to set up these kind of infrastructures peripherally. I think I should stop now.
Thank you. No, that was like really comprehensive, wonderfully put. Dr. Mosipele, same question for subspecialties. I know you and I were working with Glenn and Dr. Parmachek on maybe fellowships, then COVID happened, but yeah, what are the gaps? What's being done to address them in terms of medical subspecialties, and how can BUP or Harvard or Baylor, like some of these foreign academic institutions that work here can be to support the.
Thank you very much, Corrado. I think I will echo the same sentiments as Dr. Miller. And I think in the past 20 years, one thing we've done very well is to focus on the traditional model of training clinicians, training scientists, you know, mostly epidemiology and public health. But I think there are a few things. And when you look at a healthcare system and strengthening a healthcare system, a well-trained workforce is only one element. And therefore, one of the things and that we could look at, I think, going forward, it's not just specific to subspecialties, is to look at the other parts, digitization and high availability platforms for us to have good data source. It doesn't only help research, it also provides a safe platform for patient information management systems. Reliable supply of consumables, maintenance of equipment, you know, are very, very important for us to have a strong healthcare system that is resilient, that can ensure and, you know, the security of our, you know, the health of our people, and also really better health and economic growth. So I would say within the health system strengthening sort of approach, we've all focused on one element, and probably going forward, we need to think of innovative, transformative projects that help bring these other pieces into the fold so that we can impact them to support this well-trained staff that we have and we are planning to expand. And the same tone in a conversation that you and I and Dr. Pamachek and Prof. Masire had a few years ago related to leadership in healthcare and academic medicine. As we grow this pool of well-trained doctors and researchers, most of them have not had intentional training on leadership. So it's going to be very, very important that we come up with a deliberate plan to train the upcoming leaders in healthcare and academic medicine, acquire the right skills, whether it's advocacy, negotiation, financing, strategic planning. We need to have a pool of leaders who are properly capacitated as they come up so that they can look at these systems and help them grow. And finally, and this also does not apply to subspecialties in medicine, it really speaks to just talent management across the board. And the question that I want to ask, you know, ourselves is, as we train people in research methods or clinical specialties, what have we put in place to ensure that we protect nature, this talent, and keep it engaged so that we can achieve the things that we want to achieve? What is the extent of alignment between our mission, vision, objectives, and the aspirational growth of these young professionals that we are training? And unless we wrestle with that topic, we will continue to see them come and go. And what we said earlier, that our private sector seems to be getting the better ones and some of them, and we are being left out with a few of them. So, you know, issues of mobility are very interesting for the younger professionals, flexi hours, flexi appointments, clarity in career growth when they start, and some of them leave us because they're not sure when they will go for residency or for subspecialty training. So I think that's one piece we focus on, training in the traditional model, but I think focusing on softer skills and traits around leadership, talent management, and a system, and not just putting people in there that maybe end up getting sometimes frustrated. Thank you.
Wonderful answer. And, you know, unfortunately, the clock is running so fast. We're like, yeah, as much as I hate this, I mean, we may have to stop here. I guess, yeah, because we're running 15 minutes late, and I also want to do justice to the poster session. So I guess it's also a sign of how successful the symposium was. We need to do one of these once a year, I guess, to answer all the questions that people have and make all the points that need to be made. But thank you so much to the panelists. This was wonderful. I so much appreciate it. I know all the attendees so much appreciated you taking the time and being here we all look forward to working with you for many more years to come. Back to Glenn for the closing remarks, and then we'll move on to the poster sessions. Glenn, back to you.
Thank you, Corrado. Let me get organized here. Well, thanks very much, Corrado. And thanks again to all of today's panelists for a wonderful discussion. Actually, what Toko and I were discussing, I put a little bit of a comment in the chat just a second ago about Mosopele's comment about leadership. This is something we had been discussing, and Penn actually runs a wonderful program from the Department of Medicine in concert with our business school, the Wharton School. It's an on-site program, so we'd have to think of ways of tweaking it, but it's extremely, extremely great. And so I think there are ways of doing this. And, you know, as we work in different parts of the world, the biggest problem we see, beyond all the obvious ones of, you know, supplies and stock and professionally trained people, it's actually medical leadership and how to organize and run the programs that ends up being almost always one of the main stumbling blocks when things don't progress, you know, as ideally as we might hope. So Mosopele's points, as not surprisingly, are absolutely well taken. I want to begin by just highlighting for everybody the poster sessions again. So I'm going to just do a quick screen share and see if I can get this up here. Okay. You will see in the chat room the link to the poster sessions. So remember from yesterday that you go, okay, so the poster sessions are listed here. Can you see my slides? Yes, I hope so. The poster sessions are here. I won't read through them in the interest of time. Again, they're concurrent. So you're gonna go forward. Once you enter the Zoom link, which again, the link for that is in the chat room, give it just a second after you get there, because the hosts of the meetings have to essentially become the host, as it were, and set up their room. But then you click on this, you know, this little grid at the bottom of your screen. Once you get to the Zoom breakout rooms, pick the session you want to go to, ask to join, say yes, and then you'll be admitted. So give it just a moment after you get over. All right, let me think that's probably all I need to say on that. So we're entering the end of the formal session now, as we, you know, we'll finish with our posters. This is the last time we'll be together in a group setting. And I just want to take just a few moments to thank all of the people who participated in our session and all of the organizers. We had a wonderful planning committee, of course, led by Corrado. Doreen played just a very, very critical role in getting this all together. Megan Doherty here at the Center for Global Health, Dr. Malavogo. And, you know, although Watoko was not actually a member formally of the planning committee, thankfully, she was in most of the planning committee. I don't know how this happened, because she should have been. And she was, of course, a wonderful co-host along, you know, which I was happy to share with her throughout this entire session. So we couldn't have done it, Doreen, without you, and Watoko in particular. So I want to thank both of you especially for helping get the symposia together. You know, the BUP staff throughout all of this, through 20 years, we can't, you know, we've talked a lot about the faculty and the leadership and the support mechanisms like the CFAR and the founders like, you know, Harvey and more recently Robert and others who play such a critical role. But it's the staff also who keep things going. So to Pediso, Lisa, Mogametsi, Lindiwe, thank you, and others, I'm sure I'm forgetting some. Thank you all so much for everything you do for us in the BUP organization. And look, putting this meeting together was a logistical challenge. You know, hundreds of people involved, multiple panelists, presentations. This was an IT endeavor that was a first for some of us involved in the BUP organization. Special shout out to let's see, our IT coordinator, for getting all this together. His intern, Oratile, they did a fabulous job in putting everything together. Kagiso over at the university, coordinating on the UB health infrastructure side. And of course, Carado's executive assistant, Josephine, for always keeping us on track, scheduling all the meetings, bringing us together. This was really a team effort. So thanks so much to all of you engaged in the BUP administration, our IT support systems. And again, thanks to all of our panelists, participants. We're going to kick off, as Corrado and Marian mentioned, now our planning session. We've got some strong early thoughts about where we want BUP to head. We're not going to abandon the past, and our commitments to infectious disease and research, those will always be there. We're absolutely committed to that. But we think there are new opportunities for us to strike out new directions in education. Leadership training is a great example of that, but working with Wally and radiology, we've got lots of folks here keen on that, with Mose and others, and our new chair of medicine at the university and at Marina to move forward the residency programs in medicine in country. And then, of course, as Corrado was mentioning, focusing a little more as we go forward on rural health, what that means and how we deliver care, essential care really in more difficult settings than coming into the main hospital. So we're really excited about this. We're at a point both for your country and ours. We're now in a much better situation to start traveling again, carefully, of course. And so we hope to be together soon, and we'll certainly kick all this off beginning just in the next month. So thanks again to everyone. Be sure to enter the Zoom link over on the right in the chat room and follow the directions. And again, have a wonderful day and a great weekend. Bye-bye.
Thank you.